All right. Welcome back to the Hurwitz Lab. And I'm always excited to podcast with Dr. Segal, and I seem to be doing it a whole lot lately. And I think that's because he's a super bright, college-educated guy that I've continued to learn from for over the last 20 years. And in fact, he's no longer really a guest here. He's more like a co-host or a host at the Hurwitz Lab. Now, we've been working together on a series of long-form podcasts to tackle some challenging but fun renal physiology topics. So don't forget to check out our podcasts on water balance, acid base, and potassium. And if you're enjoying these podcasts, please click on the like button and don't forget to subscribe, Alan. Okay. Today we have Alan back to discuss the very cool topic of flow. And the term flow has got a lot of attention recently because we talk about the flow state and we talk about being in the zone. And I promise if you hang in there today, you may get there, but that's not the flow we're talking about. Today, Alan's going to elucidate for us the importance of flow as it applies to every level of human physiology, from the flow of ions across cell membranes all the way to the macroscopic flow of blood. And we'll dig into the relationship of flow and driving force. And then Alan's going to present for us his novel glomerular hemodynamics model in the form of an electrical circuit. Alan, welcome back to your new home at the Hurwitz Lab.
Well, it's great to be here, Craig. And, you're right. It's interesting you said the flow state because I am going to touch on that, actually. And what's interesting is that I've been giving talks about flow to the medical students for at least 10 years. And what I found interesting was when I looked around the web to see how much is out there on this kind of thing, there's amazingly little on it. And so I'm excited about it because I'm wondering, it's so much fun and it's so fundamental, fun and fundamental, that you would think there would be more out there. And there isn't. So I'm excited about this for even more.
And I think with everybody looking at these GFRs and estimated numbers right. and not really having an understanding of putting them into perspective and understanding what is the real number and right. what are we really talking about.
Exactly.
I think this is going to be really important and fun and excellent.
Okay.
Good.
Okay.
You know what I forgot to do, which we're going to do on the fly? Yep. I'll have you talk about the first slide, but I'm going to set up the picture, the image of the talk. So that's right here. And I'm going to get your slide up and we'll be good to go. That's how they know it's live.
But definitely live.
Live, I got it.
Yeah. And if you give me the mouse control, then I'll be in good shape.
And there you go.
Great.
Actually, I got to do one more thing.
Okay.
I'm going to split this to that one. And there we go. And we'll be ready to go. And you got the mouse?
Okay, perfect. So so the talk is titled "It's All About Flow" because it's all about flow. And so let's see if I have control of it. I can't.
There you go.
Okay.
Now you have it.
So flow, as we've talked about before, flow basically is everything that moves, and everything that moves in this world requires a driving force and a permeability, and that's our equation that you've seen before. So here is a beautiful picture of a waterfall. And one of the things that's very interesting, here's flow in nature. And, of course, as nephrologists, we love seeing this because, this is how, this is what I show.
Looks like a big urine
This is what
flow.
I show the patients so that they can go. So do you know, Craig, do you happen to know what I think is the biggest difference between flow in the external world and flow in the internal world? They're similar, but there's a big difference. And I wonder if you would
flow. This is good. So flow in the internal world
versus our physiological world versus this nature.
Well, gravity,
right,
would be one.
Right. So gravity is, of course, providing the driving force here.
I can't believe I got the question right.
Right. And you got the question
right. No
right.
rehearsal here, folks.
You got the question
live.
right. But what you'll see here is that, you see, in our physical world, flow is mainly controlled by changes in driving force. So if you're driving a car or a plane, The permeability doesn't change. We're flying through air. We're driving our car through air, and this waterfall is going through air.
Right, and here driving force is the height.
Is the height. It's the potential
mountain.
energy of the height of the mountain. Exactly right. So here the flow is driving force dependent, where the permeability doesn't change. But the big difference is internally with our physiology. Driving forces are set up in a steady state because they take energy and they take a while to put in place, and nature wants to keep them. So the driving force doesn't change generally, and it's the permeabilities that change. So that's one of the big differences.
Cool.
So here is flow in the psychological sense. So unfortunately, this is a best-selling book. Unfortunately, the author is a famous psychologist, and he's most famous for this flow concept. Passed away in October. We lost him. But what you see here
Can you pronounce his last name?
No.
Okay, I was just
No,
checking.
I mean, I could try, but I don't think you want to. So what you see here on this famous graph of his is the challenge level on the y-axis and the skill level. So if you take, somebody who doesn't feel challenged and doesn't have a high level of skill, that's the apathy zone. And you see the other zones out here, and they're kind of what you would expect. But here, the yellow. Of course, yellow zone is the flow state zone.
And you didn't even make this graph.
I didn't make this graph, and so when people say they're in the zone, like it's if a musician is on stage, or an actor is on stage, and they really are feeling it. What they are is, especially in very challenging roles or with very very challenging tunes, they've met the challenge. And their skill level is so high that they maintain this flow state, and that is the psychological flow that people should try to strive for.
Right.
And because again, the more you stay in the zone of your flow state, at least by his hypothesis, the happier you are. And I think that that's definitely true. So keep the challenges going and keep your skills up. That's why we can still patch clamp.
That's it, and go into nephrology.
Exactly. So the challenge level of nephrology is high, and the skill level is high, and if you do it right, you can be in a flow state. Okay, so what I wanted to show is, you remember I told you I was in high school gymnast, and my favorite thing in gymnastics was floor exercise. And I remember when I was doing my best, performing at my best, I could picture it and visualize the routine in my mind. I was lucky enough to train with a guy who became an Olympian after high school, and he qualified for 3 Olympics, 76, 80, and 84, and won gold in 84 along with the men's team. And so one of the things that I show to illustrate in my own head what flow looks like in the real world, if you talk about a challenge level and a skill level, is this is Alexei Nemov in the 2000 Olympics. And I just want to play that briefly just to show you what flow looks like when you're a competitor.
Sure, we'll make sure. I don't know if they're going to get the audio.
You don't need the audio.
Okay.
I can
talk them through it.
I can talk them through it. So he's going to start off with a full twisting double back, and he sticks it right. But what I really want you to see is after this next forward pass here, what he's going to do. So there he does a forward flip, a couple things, boom. Now here's where you pay attention. Watch this. This is, I think, just amazing.
That's flow.
Backwards and forwards, and unbelievable.
Palm a horse.
Exactly, on the ground. That's the very famous Thomas flare made famous by Kurt Thomas, who unfortunately we also lost last year. Now he's going to finish the routine. Something tells me he's going to stick it. No, he's actually going to do more. Yeah, I love that move. Flexibility, all flow. And he will now, I think, finish it up here.
Amazing.
Yeah.
Here's the big one. Oof.
So, yeah.
Big laid out double.
So in the year 2000, he was the best floor exercise person in the world. And I just think it really is great how that shows flow. And so let's see if I can get it back here. Anyway, he did a great job. And let's see if
It's coming.
It's coming. So, okay. So this leads us to the primacy of flow. So in our world, oceans and rivers flow, blood flows, the cardiac output and urine output are both flows. And there's sensors for flow all over the body. The cilia, like a primary cilium in the collecting duct on principal cells, is a flow sensor coupled to mechanogated processes, including channels. The microvilli of the proximal tubule have a role in mechanosensing, and somehow or other, in ways we still don't fully understand, glomerular tubular balance, which is different than tubular glomerular feedback.
Right, okay.
But glomerular tubular balance, how the proximal tubule regulates its flow to keep up with changes in GFR, the microvilli bend in a certain way, and that's coupled to sodium transporter. So somehow or other, the proximal tubule knows when it has to up its game, and the trafficking of transport elements in the apical membrane are responsive to the way flow changes the microvilli. And mechanosensitive channels, which
we're fond of.
Which we're very fond of, we studied together, like the TRPV4 channel.
Or our non-selective cation channel.
Exactly. They're stimulated by flow. You know, they used to be called pressure sensitive, but you and I always talked about this because I never thought baroreceptors were sensing baro. Baroreceptors are sensing stretch, not pressure, and they're different. Stretch is different than stretch is flowy, and pressure isn't. And so baroreceptors were called baroreceptors because Starling, back in the early 1910 there had them named as baroreceptors. But we now know something about baroreceptors that we didn't know for sure. And that is that this year's Nobel Prize, which was just awarded the other day to David Julius at UCSF for coming up with the trip channels, which are used for sensing hot and cold and proprioception. So, I mean, as he said, the sense that we all have that we least pay attention to is probably our greatest sense, the ability to maintain our balance while we walk. So proprioception. All of these functions are underlined by trip channels.
Interesting.
So the way a chili pepper tastes hot, wasabi tastes hot, is how, and they have a huge, so these channels are unbelievably responsive to temperature in a certain temperature range. So the hot sensors are very sensitive. They do nothing up to 40 degrees.
Right. It's like it's like a filter.
Yeah. Nothing at 40 degrees. And then after 40 degrees to like 44 or 45, which is dangerous. Right. These are hugely, the gain is huge. And the signals tell you get off the hot plate. And so there's also, for peppermint, there's also cold sensing. So we enjoy ice cream, and our cold sensors. And these channels have this similar kind of gain function, but they're quiet until it gets cold, and then they open. So it turns out that the baroreceptors, and then Artem Patapoutian at the Scripps Institute, who of course is friends with David Julius, they work together. They both shared the Nobel Prize in Physiology or Medicine this year. And what Artem did was he was one in his lab in 2010 cloned piezo channels.
So did they do similar stuff where they stretched the membrane? I mean, how did they figure out that this was a mechanosensitive? Is it?
Well, it was a tour de force. What happened? And thanks for asking. What happened is
I'm just interested because it was something we were doing. We would suck back, and
we would suck back. We would suck the membrane into the pipette and exert negative pressure, or we would expose the cell to hypotonic solutions and swell them. Exactly. So what they did, their assay, because you asked, a very talented trainee in Artem's lab who did an unbelievable tour de force, took candidate clones, and basically what they did, expressed them in HEK293 cells, which we've used in our lab as well. And what he did was he would make a patch on the cell, and then he'd come with another pipette. And I think I saw in the video that they showed the same Sutter manipulator that we used. Yeah. And this other Sutter manipulator would be attached to a pipette that would actually push on another part of the cell. Okay. So this thing is sort of pushing and, like banging on the cell.
But it's increasing the volume of the cell by pushing on it.
It's stretching the membrane.
Right, somehow. It's stretching the membrane.
Yeah, stretching the membrane. And so he was doing this, and I think if I remember correctly, it was either, I think he had like 300 things to test, and each thing would take him 2 or 3 days to test.
Because it is interesting that when there's a volume change in a cell, like in tonicity regulation, the volume of the cell is changing and
Yeah.
you're stretching the membrane, but also the contents of the volume inside are changing.
That's right.
Versus the no change
Right.
when you're doing stretch or
Right.
the microvilli are moving. That's like mechanical stretch, but no change in cell volume.
That's right. And you know, of course, the cytoskeleton has long been thought to be involved in this and probably is to some extent. But as we found with our stretch-activated channel, which was exquisitely sensitive to
Right.
the on and off of stretch, we found that it was completely membrane delimited in the sense that when we would remove cholesterol from the patch, the membrane patch would be depleted of cholesterol. And immediately upon depleting the cholesterol, the channel would go crazy. And the reason it did is because cholesterol stiffens the membrane. And so by depleting cholesterol, I think we thought that we made the membrane less stiff, the channel went crazy. And then when we put the cholesterol back in the same patch, the channel's closed again. Yeah. So it was beautiful and didn't require cytoskeleton. It only required the membrane, its cholesterol, and the interactions between the lipid and the protein. Now, what Artem's lab did is this one person in his lab went through about 300 of these clones doing these experiments over 2 to 3 days for each clone. And I think it was, I can't remember, it was clone 72, 73, or 78. But one of them all of a sudden gave the big signal. And they were off to the races.
Interesting.
And what they showed, and what he showed in his Nobel talk, which I thought was so beautifully simple and elegant, is they made a knockout for their candidate gene. And they had this cage where it had basically 2 hot plates on the cage. And one hot plate would be at regular temperature. The other one would get hot. So a regular animal, a wild type animal, would spend most of its time on the regular side and avoid the hot side. The knockout didn't know, couldn't feel it. So of course, you know, their whole idea, which is why it's so revolutionary for changes in clinical medicine, is because pain is extraordinarily useful as a survival technique. But pain is meant to be brief and go away, not to persist.
Right.
And of course, as you know, from all the people with diabetes and chronic pain, neuropathic pain that we see, the problem with chronic pain and arthritis or whatever the disease is, the pain has outlived its usefulness. It just causes suffering.
Right.
So by finding appropriate inhibitors, we're trying to now make it so that people still have their acute response to pain, to move away and not get injured, and not have anesthesia for when they don't need it, but at the same time not suffer long-term with the pain. And this is all, and I think they said it during the talk, the baroreceptors are baroreceptors because they've got piezo.
Right.
And it's not baro that's being received, it's stretch. It's mechanosensitivity. So, and in the kidney, the transport of sodium is coupled to flow, bringing it back to the kidney. So flow is I would put forth the hypothesis, I'm certainly not the first one to say it, that flow is primary. And this is why it surprises me that, at least among the talks I could find online from other medical schools or whatnot, I don't see anybody giving the flow talk that I've given for 10 years because it's really very primary. So we use it every day in life. So here's a very important slide for many of us. Here's a French press. And basically you exert a pressure to cause the filter to go down. And this is very important transport first thing in the morning.
This is one of the most important devices in the lab.
Yeah, very important in the lab or the kitchen, or in my case, they're the same. But you push the plunger, that's the driving force, through the permeability, which is the filter mesh, and there's obviously different kinds of filter. A French press is an excellent way to have coffee. And the result of that transport is delicious coffee. And so we depend on transport first thing in the morning. So driving force times permeability equals a delicious flow of coffee. So as I alluded to in my first Stump Craig question, was changes in driving force and permeability are what run transport in the world and flow. In the process in the outside world, transport is usually controlled by changes in driving force rather than changes in permeability, like a car or plane, as I mentioned. But
except for a toll bridge.
Okay. I'm sure again, there's some overlap. There's some overlap. But process in the physiological internal world, as I've mentioned, because of the importance of maintaining driving forces that take energy, transport tends to be elegantly controlled by changes in permeability in the presence of a constant driving force.
But I think it's so great to think about anything in these terms of driving force and permeability and
Well-
the flow. And that exercise of going through different things and
Right.
seeing them that way helps you.
Well, when you know how you always play games with the kids on long car trips.
Right.
Well, with my kids, I would say, okay, instead of I spy
You
with
guys
my
played
eye,
the flow game.
we played the flow game, and the game was see something that's moving, identify the driving force and the permeability.
I grew up in the wrong home.
And so when we stopped the car, so well, why did the car stop? Did we hit a brick wall and have a
Right.
change in permeability? No, we just stopped the driving force. So
Great.
the kids learned early on when they saw something move.
Right.
I guaranteed them. I said, I can't make you many promises,
But I can.
But I can promise you, if you see something in the world that's moving, there's a driving force for that movement, and there's a permeability allowing that movement to occur, and that's how you control that flow. So, coming back to disease, we have many examples. So first of all, seeing, everybody who's ever had a cataract knows that a cataract causes a decrease in the permeability of photons hitting the back of the retina and activating, again, rhodopsin and other channels. And so, that's a flow disease. It's a permeability problem. And the way we fix it is we take the cataract out and we restore the permeability to normal. Same thing when anybody's had wax in their ears. And we both had probably patients. I remember a lot of patients who came and saying, I'm deaf. I'm definitely deaf.
And it just happened last night.
Yeah. And then basically what you do, take a syringe and use, again, driving force and flow to get the wax out of their ears. It was a miracle.
Right.
I can hear again.
Right.
It's a miracle. And so, anybody who's had that, again, that's just the acoustic energy, the pathway for acoustic energy to hit the eardrum, the tympanic membrane, and set the ossicles in motion. Again, that is a permeability flow problem. Swallowing, anybody who's ever had anything impinge on their esophagus, whether it's a tumor or a fibrosis, knows that, people would have, dilate esophagus for fibrosis. Breathing, of course, everybody knows asthma is obstruction, reversible bronchospasm, which causes obstruction of the airways, the small airways. And peeing, we've had many, many patients who've had their membranous urethra strangled by their prostate, and that's led to kidney failure. And probably the best example and the most important in terms of mortality is obstruction of the coronary, either by progressive disease or rupture of a thrombus, to cause ischemia and MI. Now,
I think going to vascular disease,
Yeah.
especially when you talk about renal vascular disease, in
Yeah.
so many ways, and this was from the old days. It was even now with the interventional guys, I tell them, look, measure the pressure across the renal artery, and if
Yeah.
there's no pressure drop, don't put a stent in.
exactly.
And so
Ohm's law.
that's it.
Ohm's law.
No impedance means there's no change in flow.
Okay, right. So, we mentioned before, and I'll mention again, antidiuretic hormone, which of course causes aquaporin 2 water channels to be inserted into the collecting duct, gives a permeability for reabsorption of water. And basically, when water is being reabsorbed, it's not being peed out or excreted. And aldosterone, again, is another hormone. This is the salt hormone rather than the water hormone, which controls ENaC channels along the same collecting duct. And that basically puts in or takes out a permeability for sodium. So there are two separate hormones, one regulating the water system and one regulating the salt system for either our total body tonicity in the case of water or our ECF volume in the case of sodium. So it's more complicated than this, but basically this is the fundamental. So one thing that engineering students learn early on in their education, but that a lot of people who don't study engineering may not see, is in the physical world, it's always been flow that's been relevant, and physicists have known it. So if you look at this table here, I love this table. It shows all the flux equations, and whether it's the flux equation for mass, which is Fick's equation, which governs diffusion. What you see here is all the J's in the third column. That means flux. And the other components of the equation are a driving force and a permeability. And so this table lays them all out. And the ones that are most important to us in science medicine would be Fick's law of diffusion, which is the top equation, Ohm's law, which will come into play in the electrical analogy in the bottom equation, and of course Darcy's law, which is mechanical. So there's the systems, and I think this is learning about flux equations is not a waste of time, and it shows you, because when people who use these equations and study them, they use them in the form J equals flux equals, and flux is essentially flow over defined area.
Okay.
So you'll notice that the units for the flux, the denominator is always the same, and the numerator changes. But I think this is was one of my favorite slides for a table. And if I could only take one table with me to a desert island.
Is that the one you take?
It may be this one. And a nice table to eat on. So pressure serves flow. And in our daily life, the whistling tea kettle, we know the tea is ready because the driving force that builds up for the steam whistles through the hole. And, who doesn't complain about not having a good shower? And, it's, again, a good shower head takes whatever pressure you have and translate that to good flow. And, I think I may have told you the story when I used to work at Home Depot. There was a guy that came in around the holidays, around now, and he said, I need shower heads. And I said, okay, I can show you some good ones. He goes, no. Show me the worst ones you have. And I go, funny. Oh, you're having guests from out of town. And he figures, yes, they won't stay long because he's going to have a crummy shower. So he changed out all his shower heads to the worst one he could find.
Oh, that's great.
So if you're ever staying with somebody and the shower's bad, that's a sign. That's the message. So if I ever stay with you,
yes,
and I see that I get a dribble out of the shower head,
then you know.
I know. So this came up in college with the bank account. I used to say, I need more driving force. I need more money in my account. And my dad would say, no, you need to decrease the flow.
That's
so
right.
it's not, you don't have a driving force problem. You have a flow problem. So again, the bank account could leak money. And then there's Ohm's law, as we've talked about. It's usually written as V equals IR. But really, the equation flux-wise would be the voltage divided by the resistance, or the voltage times the conductance is equal to the current.
Cool.
One thing I learned early on in engineering school is in our circuits lab, we came in, and I think I told you this, there were voltmeters all over the lab, and you could kick them and drop on the floor, and nobody cared. And then there was this lock closet that stayed locked for the first couple of weeks of the class, and we all wondered, what's in that lock closet? What's in the lock closet? And so finally, in the fourth or fifth week, our TA took out the key and said, ooh, there's the key. And he's going to open the closet. He's going to open that cabinet. And in the cabinet was beautifully, shelf after shelf of these beautiful black Simpson ammeters. And we said, well, why are those in the closet? He goes, well, these things that measure voltage or driving force, they're a dime a dozen. We don't care if you bust those. But these fine flow meters, these are current meters or electrical flow. And these are sensitive and expensive.
Right. So
it's more expensive to measure flow. And this translates to what we do in medicine. We've been measuring blood pressure since 1733.
Right. It's easy to measure the height of the mountain, but it's much more difficult to measure the flow of the, river going over the edge.
Exactly. And so it's now been almost 300 years that we've been measuring blood pressure.
Right.
As you know,
and where has it gotten us?
Yeah, well, as you know, blood pressure was first measured in a carotid artery of a horse.
Right.
I
remember that old picture.
By Stephen Hales. Yeah, I have the picture. And I think he had his med student go up and in a tree. But anyway, we've been measuring it for nearly 300 years, and we're still arguing about what these two numbers should be.
Right.
Can you believe it?
It's like PTH. It's because we don't know what they should be. And they don't correlate because it's about flow. They're measuring the wrong thing.
Exactly. So this is the point, I think, and I think you said it for me. Blood pressure we measure because it's easy to measure. Right. You could measure it at home, and maybe your phone can measure it soon, or if not already. And in meeting after meeting every year, whether it's KDIGO or the Heart Association, whoever, is arguing about, and over the years, what we've basically seen is a coming down of the target pressures. But still, and even in preeclampsia, the obstetricians want those patients, they don't call them hypertensive until they're above 140 over 90. And pregnant women, I don't know that's not a pressure I'm comfortable with in a pregnant woman, but that's what they say. It's controversial. And yet we're still having every year the 2021 guidelines will come out, and it's what should a diabetic be? But if we could always measure flow, we could have always measured the flow to the tissues. I think we would have thrown blood pressure away a long time ago. It's easy to measure, and certainly easy to measure on the fly. A sphygmomanometer is cheap, and a flow meter is expensive.
Yeah.
And,
well, what about using Doppler to look at organ flow and perfusion? And
well, I think your point that more effort should be expended into coming up with better ways to non-invasively measure flow is, I mean, if you ask the brain, what's the blood pressure?
Right.
The brain will go, I don't know. Well, brain, what do you know? You're the brain. And the brain will say, well, the first thing I know is I need to be around so you can think about the kidney. But the brain will say, look, man, I measure, I know my metabolic needs. I know the oxygen I want delivered. I know the waste products I got to get rid of. I need a certain flow for that. And by the way, even though it's more complicated than this, and we'll get to it, I auto-regulate my flow.
Right, exactly.
I mean, if I cared about pressure, I wouldn't be auto-regulating my flow to have a relatively constant flow in the context of changing pressures.
Right.
I don't know what the blood pressure is. I do know what my arterial diameters are going to be so that I can regulate my flow. So brain says, you want to talk about flow? I'm all about it. But I don't believe that your brain knows what your blood pressure is. And I don't think the kidney knows what your blood pressure is. I just don't. But I could be wrong about that, but I just don't. I think it's paying attention. Cells and tissues and organs
care about flow.
They care about flow because that's where they're getting their stuff. So nature is flow. And so one thing I wanted to just point out as a point of how we use this, people may not think about this, but we're using these concepts of flow all the time, even if we don't know it. So about 10 years ago, the DDAVP clamp for severe hyponatremia came out. And now most of us will manage to avoid overcorrection of hyponatremia. Will use what's called the DDAVP clamp, basically turning the patient into a beaker. And here's how that works. So patients
I just did that this week.
I'm sure you did.
They turned themselves into a beaker.
Right, but the question is so we do it, but do we think about what's fundamentally that we're doing? So patients with moderate to severe hyponatremia have a low plasma sodium concentration by definition, and they have this large excess of body-free water. So there is a very large driving force for water excretion, because concentration is a driving force.
Right.
So there's a very large driving force for excretion, ask Fick. But what happens, especially for patients in certain categories, is once they're admitted, they can have a spontaneous aquaresis where they lose water so fast that their sodium concentration or their tonicity overcorrects.
Right.
And that's dangerous because it can produce osmotic demyelination syndrome. So I suppose a couple of good examples are, for spontaneous aquaresis, the polydipsic patient, the psychogenic polydipsic patient or the primary polydipsic patient who's drinking water, and then their normal kidney starts to excrete it rapidly when they get hospitalized. They're at high risk if they've drunk themselves down to, I saw a patient drink himself down to 112, okay? And he's making tons and tons of urine as he comes in intubated.
Right.
Well, he's going to overcorrect.
Right.
Okay? And you got to put a brake on that. And DDAVP, instead of trying to keep
Match
up with this
water
water loss,
right.
which is a nightmare for the nurses, what you just do is flip the switch.
Right, and have them retain some water.
And have them retain some water and stop it so you can control it.
Increase, basically, the permeability for
water reabsorption. Right. So another category of patient is the thiazide-associated hyponatremia patient who the thiazide is going to be stopped, and now they're going to excrete water as the thiazide wears off. Those people also need to be clamped. And then certainly hypovolemic patients who are going to rapidly excrete water as you replete their volume. So basically what happens is that for this spontaneous and unpredictable aquaresis puts the patient at higher risk for overcorrection. And so by using the DDAVP clamp, you're able to basically turn the patient more into like a beaker, so that while you're adding your negative water or your hypertonic saline, instead of having two things going on at once, I'm adding hypertonic saline and the patient's losing water. Okay, once you've stopped them drinking or you stop their thiazide, you can turn them into a beaker, so to speak, because you've shut off the lower valve permeability in terms of water excretion. And now you basically can control that beaker by adding your your negative water or your 3% saline is.
Gotcha.
Or I can always think of it as negative water.
Mm-hmm.
But it makes your equations, the Droege-Medius equation, for example, is it's okay, but one of the drawbacks to it was
It's not mass balance.
no, and it doesn't correct for what the patient could be losing in terms of urine water, and this DDAVP clamp, basically what it does is it allows the Droege-Medius equation to be more reliable. Of course, that came from the Edelman equation. So I think it's funny that, we all learned about it as the Droege-Medius since it came out in 2000. But let's remember the 1958 JCI paper from Izzy and the Edelmans.
Gotta love the Edelmans.
Gotta love the Edelmans. And that was where it all came from. So again, here's now where I want to transition to talking about flow in the body.
Okay.
And I love this picture I once found from a person I don't know, and I've tried to find if this ever was in a paper, but I can't. It's just a picture I once found and can't find again. Found it about 10 or 15 years ago. And I think he might have been from the UK because it's a tea analog. So the blood is in the teapot, and then the filter is the glomerular filter there, and that's where the tea leaves are. And the cardiac output turns the red blood. The cardiac blood flows in this filter, and then you get the
Ultrafiltrate.
You get the ultrafiltrate, which is yellow in Bowman's capsule. And so to continue this, let's put some numbers on this. So cardiac output in general about 7,200 liters a day, and the renal blood flow being about 20% of that is about that much per day, 1,440 liters a day, which is interestingly the number of minutes in a day.
Exactly, I love that.
So the one way to think about the renal blood flow is about 1 liter a minute.
Right.
Okay, and then you have the GFR, which is about 180 liters a day, and that's what's getting into Bowman. Okay,
but we're not putting out that much urine.
No. So there's some calculations.
Amazing.
So there's some calculations on the right, and if you assume a hematocrit of 40%, you can calculate the renal plasma flow is about 864 liters per day. Now the GFR is about 20% of the renal plasma flow. That's giving us the thing called the filtration fraction, which is about 15 to 20%. Let's say 20%. And so through the proximal tubule and the loop of Henle, as you intimated, you're not going to be making all that as urine. And so what happens is you go through the nephron, as shown there. What's happening is you're going in and out of the cortex and the medulla. And the result of this is a final urine output of, again, about 1 milliliter per minute per day. So, I mean, if you make 1.5 liters of urine and there's 1,440, roughly 1,500 minutes a day, you say, what are your kidneys doing? Well, if you have 2 kidneys, they're each producing about 0.5 mil of urine a minute. That's what a kidney's doing. And if you collect it from both kidneys, it's 1 mil of urine a minute. And this is why we can easily say, that's the normal urine output. And then we know what oliguria is when you can't keep up with your solute load. So the urine output turns out to only be about 0.8% of the GFR, and a tiny percentage of the,
I think it is worth mentioning because you brought up oliguria, and you always do such a great job of describing it, that so many people get confused about it because they're always like, oh, well, it's below 30 cc's an hour. This has got to be oliguria, or less than 500 in a day, or less than 300 in a day. And they ask me this all the time. Yeah. And it's always interesting. So comment on that if you don't mind.
Well, I think that in a lot of the books we read, you would see that oliguria would be defined by a number, like 400 or 500, less than 400 or 500 mils a day. And it was always disconcerting to me just to see a number out of nowhere. Right. It wasn't corrected for their body weight. It wasn't corrected for what was wrong with them. And it tended to say that if you were over 500, you couldn't be oliguric. All of those things aren't true. Right. Okay. So I have seen patients with a urine output of 900 or 1,000 who are oliguric based on their solute load. Right. They're not getting enough solute to stay in solute balance as they should. And I've seen wasted patients like that. And so they're not oliguric. I mean, they are oliguric even though they're at 900. And patients who, where does the 400 to 500 come from? And that's very simple, it turns out. So if you're a person who's young and healthy and you can concentrate your urine to 1,200 milliosms per liter of urine or per kilogram of water, and if your obligate solute load per day is 10 milliosms per kilogram, which would be, let's say, 600 if you weigh 60 kilograms, then clearly you have to get rid of 600 milliosms a day to stay in solute balance, because you got your You're obligated to make 600. So if the normal loop of Henle tip can get to 1200, how many, you can stuff 1200 milliosmoles in a liter.
Right.
How many liters do you need to stuff 600?
Yeah,
you need 500.
500 mLs.
Right. So basically, the functional definition of oliguria for me is, first of all, if you're 85 years old, you ain't getting to 1200 anymore.
Right, exactly.
Okay. This concept also becomes relevant to obstructive uropathy. So, there's a lot of people that say, Doc, I can't be in kidney failure, I'm still peeing.
Right.
And so you and I know that having a urine output, and we'll get to this, having a urine output and having a clearance.
What's the example you give for a patient if that's their case? I have my standard. I'm always like,
well, why don't you tell me your standard?
My standard is I'm always like, it's like a dishwasher with no soap dish and no rinse cycle. You hear the water going, but then you open it up and it's all dirty.
Well, I'll show you my example.
I want to see yours.
Yeah,
we're probably going to see yours
It's coming
soon.
up. It's coming up.
Good.
So it's coming up. So, yeah, so you don't know that, so this is live.
No, I love that.
Yeah.
Love
so the other thing we see this is the man who becomes obstructed over time, where the prostate comes in and gets the membrane of the urethra. So one of the questions I love to ask the medical students is, if a man has obstructive uropathy, compared to being when they didn't have obstructive uropathy, would they come in with having more urine output, less urine output, or the same urine output as before? And the majority of the class gets this wrong. They will almost universally vote for less urine output. And the truth of the matter is, it's more. Because polyuria, men with obstructing prostates know they get it more often. Now, why? The reason is very simple. They can't concentrate. So as the injury progresses, if they were, let's say they were able to do 1200, they certainly aren't going to be able to do 1200 when the collecting duct is damaged from their longstanding obstruction. So now let's say instead of doing 1200, they can only do, 600. Okay. Well, now if they're making 600, in the old days, they only had to make 500 mils of urine.
Now you gotta get a liter out.
I got to get a liter out. So students always say, oh, Dr. Segal, you're crazy, because everybody knows obstruction's got to be less. And that's the funny thing.
And it's a good example, because if they can only get to 600, in your example, if they make 999, they're oliguric.
They are oliguric if they make 999. And that's the point. So you lose that driving force that the collecting duct gives you, loop of Henle collecting duct give you. It's a married pair. And so when it shows up on the boards, and it's a decent boards question, the answer is, and answered by the minority, is that having obstructive uropathy is a cause of polyuria. And that even with that polyuria, as you say, if it's 999 instead of 1,000, that's oliguria with polyuria.
Exactly. I love that.
Oliguria with polyuria.
We might have to label this talk oliguria with
that's
polyuria.
A trademark.
I love it.
Polyuria
Beautiful.
with oliguria.
That's a definite Alanism.
Okay, so that is a thing. That's a possible thing.
All right.
So anyway, to finish out the slide, just to give you some numbers, there's the numbers of the flow in Bowman's, and Craig, you can probably read it better than me. What does it say there? GFR?
You got a GFR of 120 mLs per minute with 2 million nephrons, and then you get a single nephron GFR of 60 nanoliters per minute.
And measurements show that that's pretty darn close. Okay. And then there's the flows. I can't read those either.
Urine volume, 1440 mLs per day. You got 2 million nephrons, get you 500 picoliters per minute per nephron.
Yeah.
Of flow out.
Okay. And a picoliter is a millionth of a millionth.
Right.
Okay. Yeah. So that's a good number. So in the net, as you mentioned, only what?
99.2% reabsorbed and 0.8% excreted.
Right. And this is going to, and so if you're looking at that 0.8 and you're trying to talk related to clearance, this is a small tail trying to wag a big dog. So that will get to my, and that will come in, you'll see that with my example. So here is, again, I've shown this slide before, but I love it. It just shows the 4 major processes in the kidney. There's filtration across the glomerulus, and then the fate of something that's filtered, and again, freely filtered, just to mention it. People are confused by the term freely filtered. Freely filtered means that the concentration of substance in the afferent arteriole and the concentration in Bowman's are the same.
Right.
So if you have a glucose concentration of 100 milligrams per deciliter in your afferent arterial, all of that, enough glucose is going to be, it's really filtered. And so if you test Bowman space and you say, what's the glucose here? It's going to be 100 milligrams per deciliter.
And how is it that you have a zero clearance for glucose?
Yes. So even though it's freely filtered, the reason you have a zero clearance if you're normal is because I think somewhere in the proximal tubule,
It gets reabsorbed.
I think it gets reabsorbed.
Unless.
Yes, and SGLT2 inhibitors.
There you go.
Right, but that's again, that's another everybody's very hot on the flozins and the flozinators, and everybody's got their badge that I'm a flozinator, and basically what flozinators are doing to the benefit, I think, obviously these studies are impressive with their benefit of preservations of kidney function and improvement in heart failure, is the mechanism is the SGLT2 inhibitors are interfering with the flow. Right. So that normal reabsorptive flow of sodium and glucose through the SGLT2 is being stopped. And so you're getting an offloading of sodium in a natriuresis and an offloading of glucose, which can cause infection.
Right.
So you got to pay close attention to hygiene. But the bottom line is that the flozinators say, look, this natriuresis and this glycosuria is way worth it. But if you dipstick a urine in clinic now, all these folks are going to have 4+ glucose.
I know.
So you can't use that anymore. In the old days, it was 4. Oh, you got.
I'm like Fanconis.
Yeah. Something's wrong, or hyperglycemia.
Right, exactly.
But they might not be hyperglycemic because now you're blocking it all. So reabsorption is a big thing. Proximal tubules does 2/3 of that for most of the GFR. So most of the GFR is reabsorbed in the proximal tubule, 67% or what. And then, of course, secretion, like potassium, in the distal nephron. And then what ends up being excreted is whatever is filtration minus reabsorption plus secretion. So again, just to remind people the directions, reabsorption and secretion are just the two arrows. Reabsorption is called reabsorption because it goes from the outside world, the urine, back to the inside world, the blood. And secretion is just transport in the other direction from the blood, the inside world, to the urine. So just because you're reabsorbed doesn't mean you can't be secreted. And just because you're secreted doesn't mean you'll be excreted, because it could still be subsequently reabsorbed. Okay, and I think I wanted to say, there you see, we're going to get to glomerular hemodynamics. There you see the afferent and efferent arterial, and we're going to come back to what controls those, because those are the resistances that control flow, that basically regulate GFR. So we'll come back to that in some detail. Okay, so clearance is a tough thing for people.
Very.
Very tough thing. A clearance, first of all, is a flow rate. GFR is a clearance. And so we'll talk a little bit about clearance. Clearance is a tough concept for people. And what usually happens in physiology classes or in books is a student looks up, oh, I'm confused about clearance.
Right.
And that's normal. I mean, if you're not confused about clearance, you're not looking at clearance.
Right.
Because
it's a confusing topic.
It's a confusing topic, concept. And so what you'll read in the book is that a clearance is the volume of plasma that can be completely cleared of a specific solute in 1 minute. Right. And a student reads that and draws a complete and total blank. Right. It's almost like you said it in Martian.
Yeah.
It's the volume of plasma that is completely cleared of a substance in 1 minute.
Right.
Yeah. So I don't get it. I don't get it.
Right. Because you would think if you're decreasing a solute in this, that the concentration goes down. But the way they want to say it is, okay, you've removed this much solute. That means keep the concentration the same. Mm-hmm. But now you have this one little segment of drink that has nothing in it, right? Yeah. So your volume is the same. But now this is the clean part, and all this has the same as what you started with. Right. Isn't that what they're saying?
I guess in a way it is. But all I know is what they're saying is not
confusing.
Understood. It's not understood.
It is confusing.
And so I've had many students be able to say back to me what clearance is.
Right.
And then I would follow it up with a couple of questions that made it clear they had no idea what clearance was. So to be right, that's why multiple choice questions are not that great. It turns out that, I know you were on call this past week, right?
Right, yes.
So my question is, in terms of the things you faced this week, how many of those were single answer multiple choice?
None of them.
Yeah, because you remember when you went to the ICU to see a case and the nurses said, okay, Craig, it's
A through E.
It's A through E, Craig. And we're calling you just to figure out which one you're going to pick.
Which one do you want?
And you didn't think about it like that.
No,
never. But yet that's the way we test.
True.
Okay. So again, I believe that there are people who get the clearance question right because they've memorized the crazy thing.
Right.
You know, just like you memorize something in the foreign language. You don't know what it means, but you can say it. And so they'll say, oh, yeah, clearance, it's the volume of a plasma that can be cleared of a substance in 1 minute. But they have no deeper understanding.
Yeah.
So the one way to approach it is to use what I think I talked to you about way back when was the lawnmower analogy. So let's say that the box on the left here represents a lawn that's 12 meters by 12 meters. Okay. And let's say there's a normal GFR associated with the clearance of this lawn. So what happens here is if you have 2 million little lawnmowers, and each of them is very narrow, if you push them for a minute, you clear the whole lawn. So now you got mowed grass. So you started with the unmowed lawn, and the lawnmowers are all set up. All 2 million of them are set up, and you say, go. And then you give them a minute. And the normal function is in a minute, they clear the whole lawn, okay? And you say mowed lawn is 144 meters squared per minute.
Right.
That's a clearance.
Mm-hmm.
So even though that's a real-world clearance,
right,
it's the area cleared per minute.
Right.
That whole lawn was cleared in a minute, okay? Now, on the right is the same lawn, but now either half the nephrons don't work, or more likely, all the nephrons work less well.
Right.
Okay? And here's what happens. In the minute, you get this. And so the minute goes by, the same minute on the left, you got the whole lawn mowed, and on the right, only half. Because you have some sort of disease and that disease is affecting clearance. Mm-hmm. And so this is exactly, if you look at the 2 million lawnmowers and call each of them a nephron, and then you have kidney disease that's affecting all the nephrons, or some combination of the nephrons, where either other nephrons have to work harder to make up for the deficit. The bottom line is that's half the lawn. And by the way, all you have to be is above 60 in the old days to not have kidney disease. But look, that's noticeable.
Definitely.
So,
no question.
Anyway, so let's just look at the weekly creatinine clearance in health and end-stage kidney disease. The healthy kidney, as we said, the GFR is 180 liters a day, and a week is 7 days. That's 1,250 liters a week. So you're clearing. So the amount of creatinine, essentially, that you're clearing you can, in a week, a normal kidney can clear 1,250 liters, that whole volume of creatinine in a week.
To zero.
To zero. Now, dialysis, people have a creatinine clearance or a GFR less than 10 milliliters per minute. They have usually to go on dialysis at some point. So let's just say 10. Some people obviously can wait until 6 or 5 or 4.
Sure.
But let's just say 10.
Okay.
All right. Let's just see what they get. So their endogenous clearance is 0.01 liters a minute times 1,440 minutes a day times 7 days, and that's 100.8 liters a week. That's already pretty low compared to the 1,250. And what does hemodialysis give you? So the blood flow in hemodialysis is 400 mils a minute, and your treatment is 4 hours.
4 hours.
So that's 240 minutes. And you get 3 treatments a week. It's 288 liters a week. Right. So if you're on dialysis, and even if you're on dialysis, you have no kidney function. Okay. Right. So the best case scenario is your creatinine clearance is 31% of normal. And if you have no endogenous clearance, it can be 23% of normal. So you're living your life on dialysis, but at 23% of the normal clearance.
Right.
And you would predict if clearance was important, that those people are having a harder time than if they weren't on dialysis. So now here's a question for the country doctor. How many patients have you seen who lived longer because they went on dialysis?
Yeah. I mean,
it's hard to think of one.
Yeah, that's dialysis keeps people alive for a while, but they would likely be dead before,
Right.
So
so having some clearance is better than having no clearance.
Right.
But it's certainly always better. And how many dialysis patients have you not wanted to get a transplant for? Same number.
Right.
All of them you want to get a transplant
right.
for, because and every study shows that you do better with another kidney. Now, it's not a shocker to find out you do better with another kidney.
Right.
I mean, I asked my kids before they could talk, which would be better, to be on dialysis or to have another kidney? Right.
And it's probably not even all a clearance issue.
Oh, no.
No, there's so many factors but it's a big part of it.
But clearance, clearance is and I think I'm glad you brought that up, because clearance is how we assess kidney function. I'm disappointed. Clearance of all, the kidney
It's
does.
like creatinine. Why do nephrologists suck with biomarkers?
I don't know.
Suck with biomarkers.
I don't know. It's sad, but the thing about it is that off the top of
Can't
our
we
head,
get a high sensitivity creatinine?
is off the top of our heads, we can come up with 10 things the kidney does. Yet, the only way that we've ever had to really assess kidney function to this day is still by GFR.
Right.
And we can't even know that. We can only estimate it, and we can't do that well.
Right.
Okay, so the kidney does 10 things. We're going to take one of them and assess the kidney with that. Okay, good. And the one thing we're going to take assesses GFR. Okay, good. Oh, yeah, we can only estimate GFR. Okay, that's not so good. And the equations we use to estimate it are population equations that don't really apply to the individual.
To you, as you're walking into my office at 6'2", 240.
So what do you got?
Right.
What do you got? So your point is great. What we need is a minimally invasive, and this is a part of what I give this talk, because one day when we come up with a minimally invasive, dynamic way to assess kidney function, whether it's GFR based or not, it's not going to use creatinine. That's
for sure.
Creatinine's in the past. Okay, cystatin C, it's more expensive, but people like using it more when they can get it. But I think what we need is instead of measuring GFR or estimating GFR,
it's like an inhalable inulin, like something you just take a puff of this,
or something that shows up in a contact lens.
Right.
So it's something that you can guesstimate clearance of something else. So whether it's clearance based, see, what I'm pointing out is the best assessment for kidney function may have nothing to do with something that assesses clearance. Assessing clearance is okay. But we may find out better. Look, I grew up with the Jetsons, and I'm going to tell you.
Me too.
I'm going to tell you, on the Jetsons, they didn't use GFR.
They definitely didn't.
They didn't. So here's back our old slide showing the driving force and the permeability leading to flow. Again, reminding people that steady state is a mass balance of the excretion rate equal to the production rate. So here's why that's relevant. That's relevant because, again, this I think goes 3 or 4 times to show that the flow is
that way.
Dynamic.
Yes, that's dynamic.
That way and
maybe
dynamic.
5, 6 times.
I don't know.
You have it on repeat.
I got it on repeat. I got this. Stop. Anyway, I think I stopped
go.
it. So, one thing that people don't realize, which I'd like to just point out here, is that clearance, which is the flow rate, is derived from steady state. Excretion rate equals production rate, which means the driving force times the flow equals the driving force times the flow. And if you look at the urine, something in the urine's concentration, which is a driving force, times the volume of urine over time, which is a rate, flow rate, that's got to equal the driving force in the blood, which is the plasma concentration, times this other thing. So here's where clearance came from. Clearance came from the fact that we had the urine concentration of something, we had the urine flow rate, and we had the blood concentration of something.
Right.
We said, okay, what is the other side? What does the right side need to make this equation work? And the answer was, well, it needs a flow rate.
Right, it's a flow.
It's a flow rate, and the flow rate is called the clearance. So by solving for clearance, you get the classic equation that people say UV over P. It's not UV over P, Craig. It's UV dot over P. It's not UV. It's UV divided by T over P. It's a flow rate. Don't forget. So the most common mistake a student will make when you ask them, you give them a 24-hour urine, and you say, well, we'll calculate the clearance. They'll come up with some crazy number because they forgot to divide by 1,440 minutes in a day. So they come up with a creatinine clearance of thousands, and they go, well, you tried dividing that by 1,440, and now you're talking. So again, clearance is derived from steady state. So clearance pertains to anything that transfers substances from the plasma to a separate effluent, and that includes our big thing for clearance is the kidney, but the liver does clearance, the lungs do clearance, and again, people who lose their kidney function, we're all born with the backup clearance thing. It doesn't do anything in you and me, but if we lose our kidneys and we do peritoneal dialysis, once we put a fluid in, and there can be transfer across the peritoneal membrane, that's clearance. So that's how people live on PD. So clearance is the flow rate multiplied by the ratio of concentrations, and that's the equation right there. And so you could have any effluent. You do this every time you do home clinic. You ask a patient to bring in their effluent.
Right.
And we guesstimate their KT over V, whatever you want to call it, their clearance of their peritoneum. And of course, and then we try to keep that peritoneum healthy
Right.
with avoiding high glucose solutions and avoiding a bad thing like encapsulating peritoneal sclerosis. The health of the peritoneal membrane is their lifeline. And so we ask them to bring in, and we talk about whether they're fast transporters or slow transport. This is measurements made on the effluent. So they don't have a urine output per se.
Right.
Maybe they do, but what we do is we say, give us some urine, and we calculate their endogenous kidney creatinine, and call that their residual kidney function.
Right.
Okay. And then we add to that. So the overall clearance of a person
Is
say
the
whether
total
or not
clearance.
So you as a country doctor, you decide whether somebody's adequate or not
Based on those two things.
by adding those two clearances.
Exactly.
You said, I got your clearance from, and you talked about the good news, your
Right.
endogenous clearance has gone up.
Right.
And good news, your peritoneal clearance is good.
With their renal preserving therapy of PD.
Exactly. The renal preserving therapy of PD. So the overall clearance of a PD patient is their endogenous creatinine clearance of their kidney residual kidney function, plus whatever's in the effluent. And when people start to fail PD, they're not just failing PD because their kidneys are failing. They're failing PD because their peritoneum is failing. Okay, because diabetes is not easy on the peritoneum. So what's the clearance of substance X from the plasma to the urine by the kidney? The answer is the ratio of driving forces, urine over plasma times the urine flow rate. And of course, since the ratio of the driving forces has no units, the units of clearance is flow. So here's just a slide that shows that, showing that because inulin is freely filtered, it's not endogenous. We have to give people. So once you get people a steady state, once you achieve a steady state level of inulin, which requires an infusion, you can use basic pharmacokinetics in the clearance equation to find out that when they're in steady state for their plasma inulin concentration, whatever's in their urine, because it's freely filtered, not reabsorbed or secreted, that is the closest thing. And that's the gold standard for GFR. Okay, that's the gold standard for estimating a GFR. The creatinine clearance is going to be a little higher because it's secreted. Creatinine is secreted. So it's not as good, but it's endogenous, a lot more convenient.
Like 15%.
Yeah.
Like
here's a stumper question for you.
Okay, let's have it.
Who discovered inulin could be used to measure GFR, and what was the source of inulin where he got it?
That I do not know, but that sounds like a good question.
You know the first answer. Who would it be? Take a wild guess. Who would it be that would be the discoverer of that inulin would be a measure of GFR? I'll give you a hint. It was discovered probably in the late 30s or early 40s.
Not positive.
Homer Smith.
Okay, Homer Smith.
Okay,
I should have got that.
And the inulin is a carbohydrate. Okay, and it's special because it's one of the few things that is freely filtered and neither reabsorbed or secreted by the tubule. So whatever's filtered, you can use for measurement of clearance. Where was the source, or still is the source of inulin? The Jerusalem artichoke. So
Definitely wouldn't have gotten that.
So there's a beautiful Monet in the Art Institute in Chicago. And when we visited my hometown, I took the kids to the Art Institute. We took a picture of them next to the Jerusalem artichokes by Monet. And they said, yeah, that's when Monet was wanted to make a picture of inulin. It's the Jerusalem artichoke, and it's expensive. So, again, people think that I'm peeing, so I must have good kidney function is wrong. They're related. Excretion and clearance are related, but we already saw certain things. So, this is our rules for how you measure GFR. But why inulin is a good one to do that. So here's my example. You said, what's your example for why people can have a good urine and still not have good kidney function? So here's clearance versus excretion. The excretion of urine is not the same as kidney clearance. Consider two identical twins. You always know I love to use the identical. Love the twins. So let's say these two twins are twins and identical in every way, except that one of them has kidney disease. So they can both have the same urine flow rate. Okay. So again, their urine flow rate, the UFR, can be the same. In a steady state, the urine concentration will be the same for the two twins because they have the same mass, body mass, and they're making. So, the urine clearance can be much different, and here's why. So, twin A has a normal plasma creatinine of 0.5. Twin B has chronic kidney disease and has a plasma creatinine of 5 milligram per deciliter, 10 times as much. So, it's obvious that the creatinine clearance for twin B is 10% of twin I guess I should say twin A.
Twin B. Right.
10% twin A. And so the fact is, again, a question that students always get wrong is I'll present the twins to them and then give them a multiple choice question on how the two urine creatinines, the total amount of creatinine excreted by the two twins will be. And they'll think they have to be different. But in the steady state, they can't be different because they're both in steady state.
Right.
The reason that the amount of creatinine in both urines is the same is
the production rate is
the production rate is the same.
Where the production rate is the same, and they've reached a new steady state, so their excretion rate is their production rate.
Right, but yet because the plasma concentration of twin A is so low, for him to get all that creatinine in his urine, he has to filter
much higher flow,
much higher GFR.
Right, GFR.
Okay? And the twin B has this huge driving force of 5.
Right.
And so even though its clearance stinks, so it's better to have a low driving force and a high clearance, which is why we said forget blood pressure and do flow.
Right.
Than to have, to achieve, the achievement is the same. They both achieve, if you're holding both of their urines and the urine volume is the same, and you send them to the lab, the students think the lab has to know which one's which. Right. And the answer is the lab can't figure it out.
Right.
Because the lab needs the blood sample to go with it, to know which twin was which. Okay? And so here's a case where a loss of permeability, that is clearance, that is GFR, has led to a higher driving force. Because to hit steady state, if you lose clearance, you have to go up on the driving force. And the going up on the driving force that achieves that steady state is their disease.
Right.
Okay? Is their loss of permeability. It's the cost of having a lowered permeability. It's like the lung patient with COPD. They can excrete all the CO2 they generate, but at a higher PCO2 because the driving force is
so much higher.
The fact that they lost area of gas exchange, the price of that is to live with a higher driving force.
Right.
So there's no difference between the lung patient with a higher PCO2 and the kidney patient with a higher creatinine. They're both plasma reflections of the driving force that had to go up to keep you in steady state because your permeability went down. And the treatment for people that need a lung transplant, you can back their permeability.
Right.
For the people that get a kidney transplant, you can back their permeability.
Right.
And the driving force goes back to where it should be. Driving force helps you achieve steady state, but don't mean you're healthy. You'd much rather be twin A. I got to fix that slide.
Low driving force.
Like kids.
Right.
Kids run around on the playground with very low blood pressures. Low driving force, high flow.
Right.
Okay, so again, just for example, for people to take a picture of the slide, here's some data of somebody getting an inulin infusion, and I give you some numbers and say, okay, if this is going on and these are the measurements, what would be the inulin clearance? You apply the equation as I've applied it at the bottom line, and you get the 120 mils per minute of the GFR. Okay, so the creatinine clearance is the same, but notice the creatinine clearance is a little higher, 126. That's because creatinine is secreted.
Right.
Okay. So again, this is our, I don't know why I put this in again, maybe because it took a while. But it's
good. It kind of solidifies its bookends.
Yeah, well, it took a while to make the slide.
Yeah.
So I said,
it's definitely worth a double.
I got to show it twice. You know?
That was a nice one.
Yeah, that's nice. Okay. So we've seen this slide before, the evolutionary physiology, and we've seen our first space is the space of life, and our second space is the ECF. Now, here's a question for you, the country doctor.
Okay.
When students come in and they tell you a patient is third spacing, so let's have a little quick digression on third spacing.
Okay.
When they either ask you what third spacing is or they tell you they have a patient with third spacing, what does it tell you? What do you think is, what does third spacing mean to you?
I mean, third spacing to me is fluid is not in the cells, or it is outside of the cell, so it's extracellular fluid that's in a compartment that doesn't communicate with the blood vessels.
Beautiful. You've had good training. So here's what I found out on the internets. So it turns out that as of last week, a couple days ago, when I looked at this, I said, well, what are people saying third spacing is?
Mm.
So third spacing, I think, came up as a term that trauma surgeons use for what happened to fluid when they give large volume resuscitations. And again, it goes a lot of places because they give a lot.
Right.
So my definition of third spacing has always been the following. I should say this. There are a lot of people out there who say third spacing is if you're not in the if fluid is not in the ICF, and if fluid is not in the intravascular compartment, that the third space is somehow edema. That a patient with edema would be third spacing. I don't believe that.
No, because that communicates with the blood vessel.
That's why we can dialyze it.
Right.
And diuretic it.
Right.
So to me, my first space is the space of life, the intracellular fluid. My second space is divided into two compartments, 2A and 2B.
Okay.
2A is the intravascular in the blood vessels.
Right.
And 2B is the interstitium. And they're dynamically in equilibrium with each other and steady state with each other. And we can get access to both of them. So for me, edema, it means that the second space, both 2A and 2B, are expanded.
Third space is you need a needle to get that fluid out.
I think I know the guy who told you that. So I always used to say, a fluid is in a third space if you need to do a thesis.
Mm-hmm.
A thoracentesis, a
Right,
paracentesis, an arthrocentesis,
Right.
pericardiocentesis. That's fluid not doing you any good, and you can't get to it, and it can cause tamponade,
Right.
okay, of lungs and heart.
Mm-hmm.
So to me, if the only way to get to the fluid is with a needle, that's the third space. But I do want to bring it up because, first of all, I think you don't need to say third space anymore. Just where is the fluid? What's the diagnosis?
Right.
Okay, if you're telling me somebody's got ascites, yes, it's a third space, but they've got ascites.
Right.
Okay. So I don't think you need, I think two things are true at the same time. I think that what a lot of people are still saying is third space is edema.
Right.
Okay.
Yeah.
And I don't believe it is.
I agree with you because that fluid communicates with the blood vessel
exactly.
intravascular
Okay.
compartment.
So I don't think edema is third space because you don't need a needle. Exactly. And that since we can now be more specific about what the fluid is in the underlying pathology. Now, there are some things that are hard to understand. There are a lot of, or not a lot, but there are women, mostly women, who have this thing called idiopathic edema that I don't understand. Now, maybe that fluid is in a third space because it's hard to get to. So I don't know. That one may be. Of course, burn patients who weep fluid.
Right.
That's a different kind of third spacing. In the OR, they joke that there's fifth spacing. There's the first three spaces, and then the fourth space is in the fifth space are all these fluids that spill out onto the floor, and that the OR is the receptacle.
Floor is the fifth
the floor
space.
is the floor is the receptacle for the fourth and fifth space.
Oh, that's terrible.
So anyway, but I do think I wanted to mention that. I'm glad we talked about it because I was a little disappointed to see the number of people on the web
Interesting.
and things that still say edema that we would diurese or dialyze is third space.
Right.
Not a needle. So you've seen this before with the first and second spaces. The first space is the space of life, and the second space is the space of life support. So, go back to what the kidneys were for and are for. So in the old days, in seawater, down to the bottom, water was in short supply and salt was in excess. So the kidneys had to do a certain thing, and sharks show you still the secrete, show you that. Now, as we went to fresh water, now there was a surplus of free water and a shortage of salt. And as we made our way on the land, now after the kidney had spent thousands of years learning how to reabsorb every sodium ion in sight, now there's a surplus of initially there was a shortage, but now with McDonald's on every street, there's no shortage of water or salt. And so everybody's got a water bottle at McDonald's. But that's not how it was for the cave people. Even the first McDonald's was probably not in cave times. It actually was in 1954 in my hometown of Des Plaines, Illinois. Okay, close to my hometown. So the kidney got set up to really be good at reabsorbing salt, and it does it by the transport that we talked about, and that epithelia are special because you find them at the border of the inside and the outside world, with the apical membrane interacting with the outside world, at the urine, for example, and the basolateral side being the blood. And of course, these elements are different, and that's how vectorial transport occurs by a polarized epithelium.
Right.
Okay. So here's Homer Smith, actually. Speaking of Homer, he had a picture that shows how the nephron evolved from animals in salt water. Then when they went to fresh water, there needed to be, in salt water, you might not have even needed a glomerulus, but then in fresh water, you did need a glomerulus. And then the amphibian who was going on land and sea needed a little bit longer tubule, and then mammals need a loop of Henle. Okay. So nephron evolved. And this is Homer's typical, his hypothetical protovertebrate of our ancestor, of a segmented thing that had a big mouth that stayed open, that just swam. And basically each segment had two holes in it, a big hole for the reproductive stuff, which was all important, and a smaller hole for the kidney, or what would be the tubule, excretion tubule. So what this thing would do, the strategy of this animal, was it had bilateral symmetry. It was our, as Homer said, a frail ghost of our became our relative, our ancestor. It said it just opened its mouth and swam.
Right. And that was the flow.
And then it didn't worry about what was coming in. It let the kidney sort that out. And that's still how we can do it. We can basically, if you have good kidneys, you can basically go anywhere you want, eat anything you want, and the kidney sorts it out. Okay? So the kidney, in my way of looking at it imagination-wise, is that the way the kidney got formed and ends up in our back is if you just imagine each of these segments, the hole couldn't stay because it was going to waterlog you. So the hole couldn't stay. The hole's got to get closed up and internalized. And then as these all got internalized, it got pulled back into the back. And that would give you a kidney shape, whereas the segments from the front would be bigger, longer, and the segments from the back would be shorter. And you kind of get that kidney shape. That's how I imagine it. So water became a predator. And not sure why we're not clicking here, but I'll try again. Oops. So I'll go back here. Water became the predator. And so marine animals had to develop a waterproof covering. And the waterproof covering wasn't a permanent solution, so the kidney got born. But then there was all this water. At least this is in Homer's view. So I don't mind this. This is what he said, and he was pretty good.
He's pretty good.
He's pretty good. I mean, our biggest one of our biggest awards in ASN is to win the Homer Smith Award. That I'd love to win that award. Never will.
For these podcasts, you're going to win it. It's
no,
coming your way, pal.
Sure it is, buddy.
I feel it.
Sure it is. When Homer comes back. Anyway, so one way of seeing why the kidney got born in Homer's view, the Homerian view, is that all this water had to be pumped out when we went to fresh water. And a lot of, again, we all think of the glomerulus in the kidney, but the glomerulus is part of the cardiovascular system. The kidney made room for a glomerulus. The kidney said,
we'll give you Bowman space.
Yeah, Bowman space. So what happened with the kidney, here's the story I like to tell the kids. The cardiovascular system comes up to the kidney and says, look, I need in.
Right.
And the kidney says, okay, well, show me something. Because so far I'm not impressed with you.
Right.
The kidney is much older. So the kidney goes, I'm not really impressed with your cardiovascular system. And so the cardiovascular system goes and has a powwow, and they say, what are we going to do? And they have a strategy meeting. And they come up with, well, what's the best thing we ever made? And they said, I made the circle of Willis. That wasn't bad. And so they go down to the kidney, and they show the kidney the circle of Willis. And the kidney says, what you talk about, Willis?
Yeah, right.
and the kidney says, come back when you got something reasonable to show me. This thing is huge, and I'm not doing that. So the cardiovascular system, to its credit, invented the glomerulus. And it said, let's make this capillary. And let's put an arterial.
Spice it up a little bit.
Let's make it a beautiful capillary, special capillary, and let's put an arterial on both sides of it. And they go, the kidney's got to be impressed with that.
I'd love to see that pitch talk.
Yeah, and there was a great elevator talk.
It was.
So now the cardiovascular system, appropriately being proud of itself, goes back to the kidney and says, look, kidney, look at what we made. And the kidney goes, I can
work with that.
I'm impressed. So the cardiovascular system, what are you going to do? He goes, well, we're going to open up some Bowman's capsules. We're going to let you come in. Bring that nice little
tuft
of 30 or 40, whatever it is, capillary loops in. And what else you got there? You say that you got an afferent arterial and an efferent arterial, and what we'll do is we'll develop some stuff, some hormones, whatnot, and we'll endow it with special properties. And this will be, by the way, a cardiovascular system. You got any more of these where you have an arterial on both sides of the capillary? Arterial goes, no, we did that special for you.
That's right.
That's special for you. And so this is what it was. So the kidney tubule agreed to accommodate the glomerulus, okay? And so here's a picture actually from our lab where this is one of our salamander kidneys where I dissected a tubule out.
Beautiful.
And you can easily see the Bowman's capsule and the beginning of the proximal tubule, the neck region there. Yeah. And to prove it, the glomerulus just pops right out.
Yeah.
And there's the glomerulus. It just pops right out. So these two things are, the Bowman space is the invagination made for the glomerulus to fit in.
Tuck in.
Tuck in. But the glomerulus is part of the cardiovascular system. And that's why glomerular disease, this is what puts people on dialysis. Cardiovascular system is not good at getting better. Okay,
Sure.
the tubules know how to repair the blood vessels. Not so even the fancy glomerulus.
Right.
When you get glomerular disease, like diabetic nephropathy,
Often not reversible.
often not reversible. Okay, so the prenuptial agreement between the cardiovascular system and the kidney was this: we'll allow a high pressure, because high pressures are not popular, they're not safe. So kidney says, okay, we'll allow a high pressure arterial system to evolve in order to pump out the water, and a kidney agrees to do that, and the glomerulus is born. But this was long after the kidney tubule was already there, and this is when blood pressure was probably invented. And again, it's the beginning of the end, but nobody knows it. So here's what happened. In the marriage, trusting the cardiovascular system proved to be an immediate disaster because the heart didn't just pump the water into Bowman space, it pumped everything into Bowman space. And so now the kidney's going, oh my goodness,
Overwhelming.
the fire hose is here. And not only do we got to, excrete this water, but we got to reabsorb everything. So believe me, the cardiovascular system was not much help after that.
That's great.
And the kidney had to figure it out.
The Katuba. I want to see the Katuba for this one.
Know. The kidney figures out a way not to throw the baby out with the bathwater. And this is what happened. So you get this counterintuitive kidney. It's very confusing to students. Why does the kidney has this huge GFR?
Right.
Just to make this little bit of urine. And basically reabsorbs 99.2% of the stuff you put in to Bowman's. Why is the kidney so stupid? So what's the answer to why the kidney is so stupid?
It's actually genius.
It's a genius. Yes. Because what looks stupid on the outside.
Right.
Okay. So here's my little analogy to that. So if one little corner of a counter in your kitchen was dusty, how would the kidney clean it? Now you would just go over there with a little rag and
wipe that little spot up.
Wipe that little spot down. Leave the rest of the house intact.
Right.
Not the kidney. The kidney takes everything out of the house.
All of it. Empties it.
Empties the house.
And then it neatly puts it back.
It puts it on the lawn. And then it goes and gets rid of that dust, which makes up less than 1% of everything out there.
Right.
And then it puts everything back in the house.
Right.
And that's why.
And first it checks to make sure, do you need everything?
Yeah.
Because it will leave some stuff out on the lawn if you don't need it.
Right. And this is why it's this thing that makes the students wonder, how could the kidney be so dumb?
Right.
Because you put everything out there, a lot of work. Then you clean 1% and you throw everything back. But here's why the kidney does that. So how would the kidney give you a glass of water? I mean, you just go to the kitchen, open a faucet. How's the kidney make you a glass of water? The kidney would start off with saline, and then it would remove every ion from it by in the loop of Henle with the triple transporter and the ascending limb, and then the sodium chloride co-transporter and the thiazide sensitive. And that's how the kidney makes you a glass of free water.
Right.
So the kidney makes all the water it excretes. So it's very counterintuitive. That way it would clean your house, the way it would give you a glass of water. Why does the kidney do it? But the neighbors scratch their heads and go, what's the kidney doing? Okay? But they don't understand that what's actually going on is it had to be that way because the kidney has coupled, because when the cardiovascular system, I'm making this up, when the cardiovascular system threw everything into Bowman's, including the sodium, you lose that sodium, you die of shock.
Right, exactly.
Okay? So the proximal
and that happens to defects in the proximal tubule if you're born with those.
Right, or even if you're born without ENaC.
Right.
So the kidney had the first priority was get all the sodium back, not die of shock.
Right.
And then the kidney brilliantly figured out not only will we reabsorb all the sodium, but each one of the segments is going to do a little differently.
Right.
Because we're going to actually achieve everything by reabsorbing sodium, but in a slightly different way depending on where you are in the segment. That's the genius of the kidney.
It is genius.
Okay. I mean, let's just I have to have a drink to celebrate the genius.
We have to drink to that.
The genius of the kidney to do that. And that's why people say, oh, kidney nephron's complicated. It's got all these different transporters, it's got all these different diuretics. But the fact that we have the different transporters gives us the option to treat people with a lot of different kinds of diuretics to tailor what we want.
Right, to what you need.
Exactly. So this was brilliant. And when you see the brilliance of the kidney here, how can you not want to be a nephrologist?
Right.
I don't know. So now we go back to this. So again, it's the tea. It's the flow of tea, not the tea leaves that are important. So again, here's our analogy. Go back to the tea time. Okay, let's dig a little deeper. Okay, so here's a summary of the nephron. I just sort of mentioned that. You see, there's different places along the nephron. The nephron goes. So the nephron combines. The way the kidney works, the strategy of the kidney, is to endow the segments not only with a different transporter, but different permeability factors.
Right.
So down the loop of Henle, there's all sorts of water permeability. Aquaporin 1. Aquaporin 1 is all over the thin descending limb to allow water to go out while the thick ascending limb is doing countercurrent multiplication to coordinate with flow and set up the driving
forces.
So,
right.
But as soon as you turn the loop, and this is a beauty part of the kidney, as soon as you turn the loop of Henle, you go from having a whole bunch of aquaporins and water permeability to having no water permeability. And that's how you dilute the urine. Okay? And so between the combination of the actual absence of again, as we've talked about before, what makes the thick ascending loop possible, the old question was, what does the thick ascending loop have that makes it so impermeable to water? It's not what it has, it's what it doesn't have. Exactly.
Permeability.
And so the axial, what's called the axial heterogeneity of the nephron. So look at this powerful design. You've got this axial heterogeneity structurally going along with multiple different environments in the kidney, cortex, medulla, and places where permeabilities are exquisitely either not there, like the thick ascending limb,
or regulated by
ADH or aldosterone. And I'm telling you, I mean, again, there's no reason to have a collecting duct if you don't have a loop of Henle. The loop of Henle sets it up for the collecting duct. The loop of Henle does the alley-oop. Okay, but the loop of Henle is the unsung hero.
Right.
You need that because the collecting duct is a show. That's the showboat. But the collecting duct can do its thing because the loop of Henle has gone to the
sets it all up.
So the nephron. I mean, what you want to see is the nephron's not built into a hairpin for nothing. It's combining the elements in the membrane with different environments in the membrane. Just like when you've played different venues.
Right.
You're the same guy with the same guitar and the same songs. Sometimes, I mean, as a comedian, you do great. And the next night after doing great, you think, I'll never bomb again.
Right.
And you take the same material to a different venue and you bomb. And you will, well, I was the same. The material was the same. It was a different day and I bombed. It's because the local environment is important.
Absolutely.
And whether that local environment is the venue or the crowd, something was different. If you held something else constant.
You never bomb in the Hurwitz lab.
I hope not. I'm trying not to. So here's another view of the same kind of nephron thing, with blood in the body on the blood side, outside world on the urine side. And this time we're going to concentrate on a little different part of the nephron. We're going to concentrate on the glomerular capillary. And what's shown here in this slide is the 3 layers of the glomerular filter system. This is where the permeability is. Okay, there's GFR because of these holes.
That's right.
Okay? These are the holes through which filtration occurs.
And charges.
And there's 3 layers here. The first layer is the endothelium, which is fenestrated. Right. It has holes, but that's not where the selectivity is. Okay, and so the endothelium in the capillary is like, I think of this as a sandwich with a blood-soaked piece of bread being the endothelium, and then a urine-soaked piece of bread being the epithelium, and the epithelium is where the podocytes, those epithelial cells, the foot processes, the protocytes, come down, and then there's these spaces. So in the meat of the sandwich is the glomerular basement membrane, which is in between. So filtration starts through the fenestrations, and then pretty much gets through the GBM, but the filtration is mediated mostly by the slit diaphragms. And there are very important proteins in there called nephrin, other proteins. If you lack those, like kids in Finland who have the nephrotic syndrome, congenital nephrotic syndrome of the Finnish variety, devastating because they have mutant nephrin. And nephrin is basically the gatekeeper.
The zipper that holds it.
And so without working nephrin, you get massive proteinuria. Okay? And it's interesting also because in nephrotic syndrome, when these podocytes all smush together and are effaced, you think, well, protein couldn't get through because now the holes have been covered. So again, another counterintuitive thing about the kidney is normal function of the kidney is these beautiful slit diaphragms being very discrete, okay? And that's when protein is rejected based on size and charge, like you said. And when lesions occur, mutations or otherwise, diabetic nephropathy, minimal change disease, the constant finding in all forms of nephrotic syndrome is the smushing together of the podocyte foot processes. And the protein leak is huge. Why? Who knows? Okay, well, I mean, some people probably know. I'm not smart enough to know. So here's just another picture of the sandwich, of the blood-soaked endothelium and the urine-soaked other side. Here's the glomerulus as in an electron micrograph. Here is looking at the glomerulus from the outside. So there's the podocytes. If you're in Bowman's space, there's the podocytes, and you see these beautiful slit diaphragms and the way the podocytes interdigitate.
Oh yeah, beautiful.
Okay, and so here is the inside and the outside. There's the fenestrated endothelium on the inside, and then on the Bowman side is you see the podocytes.
Right.
Okay, and the glomerular basement membrane is in between. But that's a
That's a great shot.
I love that shot. It's got a little bit of everything. So this is if you're in Bowman's space looking back. I remember we took that vacation to Bowman's space.
Yeah, I love that.
That was a great time, and we took pictures. And if you're in Bowman's space and you look back at glomerulus, I just crossed the glomerular bridge there, and you take a picture. That's what it looks like with the beautiful endothelia, with the beautiful podocyte epithelia foot processes looking from the urine space. Okay, and then here's both sides. So if you're looking from the blood side, you start to see those holes. And if you're looking from the Bowman side, you see those podocyte foot processes.
Beautiful.
Okay, so it's very different, but the direction of flow is from the endothelium, always one direction, because the driving force, as I'm going to show you, is always in one direction. So here's George Pilati, who won the Nobel Prize for work he did in the 50s and 60s to really define the EM electron microscopy for all sorts of different things, and his wife Marilyn Farquhar. They worked together and they did unbelievably great work to define the anatomy here on the ultrastructural level. Okay, and again, that's again, you can start to see, and I don't know if they could really see. I can't see if there's a nephrin molecule there. It's not an immuno, but nephrin would be right in between. Right. Again, this is what you're looking at.
This is our permeability.
Here. Yes, this is the filter. So again, another view of it, looking at the foot process, and there's the filtration slit diaphragms, and right in the middle of that space between the foot processes is where you're going to find nephrin. So here's how it looks as a cartoon. There's the two foot processes, and you see the nephrin molecules on the bridging the gap. And this is a very complex set of scaffolded proteins that together work together. So if something, not only you need normal nephrin, you need normal things that connect to nephrin. And so I'll show you a couple of good pictures, I think. Anyway, so here's from the New England Journal, a beautiful shot that shows going from the kidneys and growths, the upper left there, to the glomerulus, to the capillary, the podocytes, to then the sandwich that we're seeing on the, with the endothelium. Unfortunately, they made the endothelium yellow, and they made the glomerular basement membrane purple, and then you see the epithelium. And then here's the molecular structure on the right, showing how the nephrins interact. Okay. So this is if you wanted to go from a gross picture to the ultrastructural EM on one slide, the New England Journal. And this is from Tryggvason. And the reason Tryggvason is the paper from 2006 that I show, not only is it a beautiful picture, but Tryggvason did the work that led to the discovery of nephrin, which was the cause of the mutation in the patients with, he did this work with the Finnish population. This is the congenital nephrotic syndrome of the Finnish variety when nephrin is mutant. And so he's one of our experts in this. So putting it all together, it just shows you how the cartoons and the EM go together. This is the glomerular filtration system, right? And it's always going from the bottom up and out. So there's blood on the bottom, ultrafiltrate of plasma, which looks yellow on the top. So then back to our analogy, this is what we're talking about. So now I want to talk about regulation of glomerular flow. So again, one of the points that makes the point that it is flow that is important is if you look in the vascular beds of brain, heart, and kidney, which are pretty important organs, it turns out all of them autoregulate flow. Now, the autoregulation of flow is a concept that's not new. We've known about myogenic tone since Bayliss in 1902, paper that I'm sure you read all the time. But Bayliss described myogenic response, the myogenic tone, that if you pressurize an arteriole, it will constrict against it. So why would it do that? It would do that because you try to pressurize it, going to force more flow. It constricts to keep the flow where it is. And if you depressurize it, it dilates. Okay, so this was an early observation that showed that there's autoregulation of flow. And even though it's more complicated than this slide, this idealized, what this slide shows is that over a wide range of blood pressure, mean arterial pressure, the diameter of the blood vessel is regulated intrinsically and extrinsically to maintain flow constant. Right. And
Awesome.
this tries to keep you alive. Now, there's new articles by, that I've just been reading, certainly for the cerebral bed, that shows how much more complicated it is than this slide. So I'm showing this as an idealized version of autoregulation. The point is it is flow that's autoregulated. How well it gets autoregulated, the actual dynamics of that are details that are still being worked out. But this is the basic concept. And this autoregulation applies very much to glomerular hemodynamics. So here's a slide from a friend of mine, Roger Lautenheiser. He took a glomerulus. What you see here is a glomerulus, and the afferent and efferent arterial are labeled. And what you see is what happens to the diameter of the blood vessels when they're pressurized. And what he showed is that here, what you see, and Craig, maybe you'll describe that because I can't really see it, but just describe what you're seeing there.
On the left there.
Yeah.
Yeah, no, it looks like it's the afferent arteriolar diameter in microns on the top, and then the bottom is the renal arterial pressure
that he's controlling.
So as the afferent arterial diameter gets smaller, the pressure rises.
Just reversed.
It looks like it's here.
But it's reversed.
Right. As the pressure,
as the
diameter,
he's controlling the pressure.
Right.
And then looking at the diameter.
Right. As the diameter gets smaller, the pressure rises.
Exactly.
Right.
Yeah, exactly. And then that's basically reviewed on the right, where you see as the renal arterial pressure goes up, look at how afferent arteriolar diameter decreases. And it decreases, and it's not big in the first place.
Yeah.
It's a pretty small vessels. So I think those are microns.
Like it's half its size.
Yeah, yeah. So that's so that's myogenic. That's the myogenic response. So here are the forces that govern glomerular filtration. There's the afferent arteriole and the efferent arteriole, and there's the glomerulus sitting snugly in Bowman's space. And what you see is the two green forces that favor filtration are the hydrostatic pressure in the glomerular capillary and the
oncotic pressure in Bowman's capsule.
In Bowman's, okay. And the two forces that oppose filtration are what?
Well, the hydrostatic pressure in Bowman's and the oncotic pressure in the capillaries.
Exactly.
The opposite.
Okay. So the single nephron GFR is essentially along the length of the nephron is what's given by what's called the ultrafiltration coefficient times the integral of the net driving force. So that's why I say the integral from the beginning to the end of the capillary, 0 to L, of whatever the delta hydrostatic minus the delta oncotic is, because that's the net driving force for ultrafiltration. So that's the single nephron GFR because it's happening over the length of one nephron.
Right.
So again, this is just another picture of the same kind of thing, and it puts a couple of numbers on there to show you what the numbers can be. So here is that picture again, and here are the pressures. And maybe describe, I like this slide. Maybe Craig, describe what you see. This is as you go down the branched vascular system, looking at the pressure as you move from, what is that on the left? The renal artery?
Renal artery at the top.
Yeah. So what do you got there?
There you have a very high pressure, basically
what is it
systolic pressure.
Yeah.
Right, renal artery, and then your afferent arteriole, the pressure drops.
Yeah, and you notice that the afferent arteriole is where all the resistance is.
Right, that's
where the pressure
vessel.
drop is. Yeah, that's the big resistance.
And then
vessel.
the glomerular capillaries, the pressure stays fairly constant there.
Yep.
And efferent arteriole, the pressure drops further.
Until you get to the
until
venous.
You get the peritubular capillaries.
Right,
yeah.
and so the efferent arterioles are connected ultimately to the glomeruli. The afferent arteriole comes off the interlobular artery.
Right.
And that's the beginning. So right where the beginning of the afferent arteriole is, right here.
At the top of that peak.
Yep. That would be the pressure in the interlobular artery. And then the pressure in the interlobular vein is where the efferents empty into. And that's low pressure. And then notice the dotted lines. So the dot on this figure, which I like, notice what the dotted lines show. What do they show?
They show whether you're constricting, what happens if you constrict the efferent, your pressure goes up.
The interglomerular pressure goes up.
Interglomerular
so
pressure
GFR is higher. So this is, again, counterintuitive to some people. You hear about an arteriole constricting.
Right.
But because
But
of
it's
what
post,
side it's
because it's post.
Exactly,
Right.
post. Okay. Whereas, of course, when you constrict the one that's
Pre.
yeah. So you get the two.
Exactly.
So that's kind of the range in which it shows kind of the range in which GFR can be controlled.
Interesting.
Okay. So here is basically a profile. I took this from Brunner and Rector's The Kidney. This is basically the real data. I needed some real data because I need to fit the real data. And what you see there is that over the length of the capillary, the hydrostatic pressure, delta P, pretty much stays constant, drops a little bit. But the thing that changes the most is as you go along the capillary, the oncotic pressure changes and gets higher and higher. So the difference between the hydrostatic and the oncotic pressure gets lower and lower. And so what's shaded in blue here is the net pressure for ultrafiltration. So you're filtering as long as you're in the range of blue.
Right.
Okay. And if you finish, so the ideal thing would be to filter the whole capillary. So when people finish their, when the pressures are such that filtration stops before the end of the capillary, the rest of this is called wasted capillary. It's a surface for ultrafiltration you're not using.
Mm.
On the other hand, when you have glomerular hypertension, they'll never meet. And you have injury set up. You'll have hyperfiltration. So the ideal is, and again, I would sort of...
The ideal would be to finish right at the end of the capillary.
Exactly. So one of the things, when people say to me, what should the ideal blood pressure be? I say, well, the ideal blood pressure to me would be the blood pressure
required
that is required to to use your capillary area, to use your surface for filtration. Yeah, to not too little and not too much, but just right. Now, whatever that pressure is, because the kidney's smart enough to know, hey, yeah, that's the stuff. That's the stuff. Okay, so that's really what it is. So I'm going to show you my model now. So again, here's an example of a disease.
Because it's funny because we're focusing a lot on pressure, which is the driving force for the flow we're talking about.
Yes, it's the driving force.
Right.
But it's you're going to see, and you already know, that it's the changes in resistance that are going to actually control that pressure. So it's the pressure, it's the net pressure that you need for ultrafiltration.
Right.
To make the flow.
Right.
But the thing that's regulating that is our resistances.
Right.
So what you see in this slide is that here you see no wasted capillary on the left. Right. They're normal. You're showing, it's kind of idealized to show no wasted capillary. And that disease, like glomerulonephritis, basically leads to hyperfiltration, which in the long run, because the kidney is trying to compensate for the lower GFR, so things happen, and ultimately this is going to destroy the kidney. Okay, and this is why we tried to lower intraglomerular pressure. So I took, this is data now. I took that slide and I basically fit it. So there's the PGC. That's the real line with the real slope. And that red line, that's the green line. The red line is the oncotic pressure.
Moving along the length of the capillary.
Moving along the length of the capillary. And then what you see there is the pressure. And the pressures on the left are basically real life pressure. Okay, so I could calculate from this essentially what would be the hydraulic resistance. And the long story short is the hydraulic conductance of along the nephron is 7.1 nanoliters per millimeter of mercury. So for every millimeter of mercury you go up, each glomerulus, you'll get this change in flow. So for 125 milliliters per minute GFR over 2 million nephrons with 7.1 nanoliters per minute per millimeter mercury, basically it's saying what kind of pressure gradient do you need roughly average to achieve that GFR. And the mean delta P needed is 8.8 millimeters of mercury.
Which is pretty much the average of that P net.
Yes, which is the average of that P net. And it shows, the actual, because filtration only goes in one direction, you only need to be a little bit in one direction. Right. So the driving force, so the normal driving force for ultrafiltration, overall in terms of mean, is certainly in the single digits, not the double digits even. So that's the same slide, I guess, that I probably changed the labels on. And then I took the green line. I said, what's green line minus red line? And I get your blue line.
Yeah.
Okay. And then I got blue line. There's the blue line blown up. So what I did is I said, there's the blue line. I took it from a book. Okay, I took it from a book. What happens if I go and use origin to fit it? Okay, so what did I do first? What fit did I try first? Not linear, because obviously it's not a line.
No,
So what fit did I try first? What's the simplest fit that I would try?
yeah, you did a logarithmic
A
fit.
single exponential, right?
Yeah.
So I thought, okay, well, if this is more complicated, a single exponential won't fit it. A single exponential fit it so well you can't even see the red line. So there's a red line in there.
Oh, that's funny. I do see it.
Yeah,
Now that you mention it.
So the red line is the fit to the blue line. And the fit is so good that even though you can barely see the red line, it's pretty much the blue line. Okay. And then this sort of looks, if you're an electrical engineer type person, this reminds you of what a high pass filter looks like. And so in terms of fluid resistance, high pass filter has a time constant according to the product of the resistance times the capacitance. Okay. So that's tau. Over a length, there's a such thing as a length constant. And we use this in transmission theory. And it's called lambda. So I could fit lambda. So because the exponential fit gives you lambda. So lambda came out to be 0.171. And since I already knew the resistances, because we have the hydraulic pressures, since I could use Ohm law to give me the quote resistance, I could come up that the resistance is 8.5 kiloohms of this circuit, and that the capacitance, essentially capacitance over a length, is the loss of the driving force.
Okay.
So capacitor is an energy storage or dissipating device. So even though the pressures themselves, the sources of the pressures are staying constant, the net pressure is got a capacitive relaxation to it.
Okay.
And so the delta dP/dL curve can be fit with a single exponential, and there's the length constant. So here again to remind you what the glomerulus looks like, and now what I've replaced that with is the circuit that goes with that. And what you see on the left is the voltage source representing pressure of the interlobular artery with published values, the node of the glomerular capillary pressure with published values, the venous interlobular vein pressure, and then basically what we know about the pressure in Bowman space and the oncotic pressure, which changes. So the changing things here are that this is relatively constant. This is relatively constant. This is relatively constant. What's not relatively constant is this osmotic, as we saw it move, oncotic pressure along the glomerular capillary. And of course, what's happening with the afferent and efferent arterial resistances. And again, here's our drugs again. And you can read that correct because I can't read it, but I know what it is. We'll go ahead and read it.
Yeah, no, decreased by prostaglandin E2, prostaglandin I2.
For the afferent.
Yep, and increased by NSAIDs.
Because they inhibit.
They increase the resistance there.
Right, because they inhibit the dilatory prostaglandins. And what about the efferent?
And then on the efferent,
yeah,
I'm looking at increased by angiotensin 2, which we know, and decreased by ACE inhibitors and ARBs, which inhibit that.
Right. So those are your main controllers. And so this electrical circuit is immediately clinically bedside relevant because these are the drugs that we use. And then basically by applying Kirchhoff's laws to the node of the glomerular capillary, this represents the arterial, this 625 milliamps is basically representing the flow of 625 mils of flow in the effort arterial and how it splits off. And again, the filtration fraction, which I use 20% here. So 80% goes on into the efferent and 20% comes down into the glomerulus. Mm-hmm. And basically that function I showed you is the function of how you would set up to achieve, the way you would set this up is you could set it up with a variable voltage source, or you could set it up with essentially a capacitance in it. I haven't chosen which one I'm gonna really use yet.
You do need to make this circuit,
Yeah, I should make the circuit. But anyway, and then the rest of the equations are just equations given by either Kirchhoff's laws or Ohm's law, or the basic laws that we talked about in the first slide of that table I take on the desert island
Mm-hmm.
with me. And these are the flows that we talked about in the teapot. So this is it. And here's the funny thing. The funny thing about it is I thought, well, this has to be out there. I mean, I'll Google this and I'll find 5,000 of these. And I found a little bit less than 5,000. I found like one, and it wasn't correct. So either I can't find it or ain't it out there. And when you make something that isn't out there, there's only differential diagnosis is easy.
Yeah, okay.
Either you've made something that's useless, and you're the one nut in the world that has come up with something, or you came up with something possibly useful.
And I think that's the question. And so, as the country nephrologist and people who want to apply things clinically, this definitely helps us understand resistance and the flow through the glomerulus.
Yeah.
But how do you see this from a teaching standpoint?
Yeah, well, I think that, in engineering school, when I went to my advisor and said I want to be a biomedical engineer, the advisor said to me, well, you have to pick electrical or mechanical to major in. And I immediately knew electrical, because I'm much more electrical than I am mechanical. I just am.
Mm-hmm.
So there are some people out there who are more comfortable with fluid mechanics, and there are some people that are more comfortable with electrical. So I guess the answer to your question would be this. When a typical undergraduate is studying for the MCAT, and they have to take, they have to know some fluid mechanics of physics. And some electrical physics, I would say that each student decides which one is more intuitive to them. Right. For me, again, it was electrical by many miles. And there'll be some people who are a little bit of both.
Right.
So my point in making this slide was, before this slide, you had to be you just had the fluid mechanics. So if you were me, even though the fluid mechanics are simple and I understood them, had this been presented to me first as an electrical circuit, I would have said, oh, yeah. And the other thing about this, in terms of what's useful for, is why make an analogy. One reason to make an analogy is for education.
Yeah.
But the other reason to make an analogy is because if you're trying to write a program to simulate what happens to glomerular hemodynamics as you vary things, like you want to throw angiotensin 2 in there.
Yeah, exactly. You want to put some knobs and switches on here and then say, this is what's happening with this medicine.
So
and see how it impacts R3.
Right.
You know what I mean?
So it's a guy like you who I know has written a couple programs. So if I sat you down and said, Craig, I need you to write a program to simulate.
I would go to this.
You would, I say, use your choice. You got the fluid mechanics, or you got my electrical analogy with the fit.
Right.
You would start programming and immediately realize, oh, I'm going to use voltages and currents, baby.
Yeah.
You would.
Yeah.
You would. And so there's an electrical analogy for action potentials, because that is electrical.
Right.
So it's not an analogy. It's the thing.
That's what they do.
It's the thing. So, but for me, it's always been electrical. For some people, it's going to be the other way around. Yeah. But for a programmer or somebody who's going to try to model this, simulate this in a MATLAB, Simulink,
exactly,
they're going to start with the electrical equations, Ohm's law. They're going to use Ohm's law and Kirchhoff's laws, and voltages and currents and capacitances, rather than I would think you would, I would, I don't know, but for those people, I offer this. And again, if it's no good to anybody, so it's not going to clutter.
I think
it's not going to take a lot of space up in your inbox.
Yeah.
So there's just another way, and I like to think of this, because for me, I can just look at this one slide, just for me, and maybe anybody else. Maybe it'll be useful for other people to do what I do with this slide. I have this on my ceiling, and when I can't sleep at night, I look at it and think about my patients.
That's it.
And think about and when a new drug comes out. See, when a new drug comes out, I can look at the circuit.
Right.
Okay. So what SGLT2 inhibitors are new.
Right.
Okay. Finerenone is new. Where do we put those on I can put those on the slide. So can you? Easier on the electrical model circuit than I can on the other one, on the fluid. So again, here is the pressures, and then here is the electrical current. Yeah. And to me, the electrical circuit. And to me, I thought some of these numbers were interesting about the resistances and whatnot. But we have some of these numbers from the literature, and I think the question is, where do we go from here? And by the way, I saw numbers in the literature for humans with membranous compared to normal, and that 7.1 in normal is decreased. That glomerular conductance, hydraulic conductance, it goes from 7.1 in normals to I think 3.4, 3.6 in membranous. So again, there's actual. You could take a disease.
Right.
So not only could you make the model circuit,
it changes the resistance across the conductance.
You could say here's where the problem is in this disease.
Right.
It's this element.
That is true.
It's this element.
Yeah, I mean, I think that's such a cool application. To me, that seems like,
I mean,
the exercise.
I understand my bias is electrical, so of course I'm always going to think of I think of
traffic.
traffic. I think of traffic as an electrical analogy.
Yeah.
And by the way, when traffic, there's all sorts of trafficking studies that go on to figure out how lights should change and what the timing should be.
Yeah.
I mean, city planners do this. They really, really do. I had a friend in undergraduate who one of his projects was a traffic situation. First thing he did, converted to electricity.
Interesting.
Because then he could model it and optimize it.
And I think it forces you to think about these three issues, flow, driving force, and permeability,
Exactly.
and which are applied in every disease state that we look at.
Right. So what have we done today? We went from the waterfall,
right,
and the coffee,
yep,
to the glomerulus.
That's it.
And I think
into an electrical circuit.
And there are no. I mean, I haven't found this out there. So maybe again, when you haven't found something out there, you're either insane,
right,
or it's. I like to think of it as the fact that what we're trying to do here with our podcast is try to create a and I don't want to say metaverse, except I said it, but sort of meta information, meta way of looking
demystifying.
at it. Yeah, demystifying and putting things into how these fit into all of life. And most talks I have been into and most chapters I read on glomerular hemodynamics, they're divorced completely from the rest of the world.
And I think I remember this from the talk you gave quite a while ago, a grand rounds you gave, which was really about. And it was the flow talk in many ways.
Yeah.
And it was the problems with blood pressure and that we're looking at the wrong thing.
Right.
And I think that's so interesting because no one else talks about that.
Because it's hard to measure. It's that locked cabinet.
And the question is like, sometimes now as technology gets better and we keep improving, how do we get the flow meter?
Right. How do we more look at that? Because again,
and we do have tools.
I mean, again, I think it's time to leave creatinine behind.
Yeah.
I think it's time to leave blood pressure is not the end all and be all. And if it is, it's taken us 300 years to figure out the two numbers. There got to be better ways of assessing kidney function and measuring flow. To me, I believe that in the end, look at all the Nobel Prize wins for flow.
Right.
Pressure has won no Nobel Prizes.
Right, exactly.
Okay? Flow keeps winning.
Driving force isn't on the agenda.
You need it, but it doesn't win the prize.
No.
The prize is won by the people that discover the elements that determine permeability and flow.
Right.
So again, this is at least the sixth.
Because that's where regulation is.
This is at least the fifth or sixth Nobel Prize. I mean, Ohm got a Nobel Prize.
Right.
So he got a Nobel Prize in 1920, and since then there's been at least five other Nobel Prizes.
Though, I heard.
Yeah, he resisted it. So there have been five other Nobel Prizes, including ones very well: Hodgkin, Huxley, Naren Sackman for the patch clamp technique, McKinnon for the structure of a K channel, Peter Agre for the aquaporin channel, and now David Julius and Ardem Padapodian for the sensory and mechanosensitive thermal touch receptor. So this is life, and their approach was to take the fact that they used capsaicin, they used the chili peppers. Yeah. Their part of their genius was let's marry these worlds. I mean, it's one world.
Yeah.
I mean, we don't have these receptors so we could eat chili peppers.
Right.
But they probably do something for temperature regulation.
Yeah. And I think you nailed it when you said this is life, and they wrapped it up. And
they wrapped it up, and that's what we're trying to do here. We're again, we like to get people interested in nephrology. That's fine, and show them that it's not anything mystical. It is a representation of the life we've all known. Anybody's looked at a waterfall or a river running, flowing. So this is all the same thing. To me, my coffee in the morning in this circuit, I'm sorry, this is the coffee filter. There's what's going. There's the grounds that are kept behind. There's the coffee.
I love it.
So where do we go from here? Because we're going to probably do some more talks.
Where do we go? So let's talk about that.
Okay. So where do we go from here? So
What are your thoughts?
Well, I thought that covered today. What we tried to cover today, what I tried to cover today was with you is flow in health and disease, to show the importance of flow, the primacy of it, and it led you to conclude at the end. Yeah, when are we going to start doing things with flow?
Right.
And I agree with you. Now, we alluded to but haven't talked in detail about something very important clinically, which is acute rapid loss of flow. In the case of GFR, that's called acute kidney injury. And the question is, when people say acute kidney injury 5 million times a day, how many of them are looking at that as an acute loss of flow?
Right.
That's the thought that has to be in your head. So, I mean, I could easily say to a person, I understand you have this flow in your kidney that you lost today.
Right.
They'll understand that better than they'll understand, oh, you got AKI.
Right.
Okay. And then CKD, of course, is when it happens, but it happens gradually.
Right.
So we haven't talked about those in detail, which we can.
Yeah.
Blood pressure is another thing we could talk about. And then, of course, well, what about people who've lost clearance? Well, then there's their dialysis. The country doctor is in central hemodialysis, home hemoperitoneal dialysis, and, of course, giving people clearance back with a transplant. Where are we? Past, present, and future. So let me just give you a slight look into that.
Yep. Let me
real quick.
I'm coming back.
Come back to me.
Hold on. Here you go. Go ahead.
Okay. So options for people with inadequate kidney function. Give them a kidney. I mean, this is not rocket science. So the kidney can be from a living donor.
It's got to be more than inadequate.
Yeah. A related or unrelated living donor, a deceased donor, or a lab-grown kidney, or something new. Now, we talked about last time the big breakthrough where the pig kidney.
Yeah.
So again, that goes up to number one, living donor. Probably unrelated.
Yeah, could be.
Probably unrelated.
Kidney X.
And then if in the meantime, to get them through, we do what's called kidney replacement therapy or renal replacement therapy, whatever, which is for hemodialysis either in-center or at home, or peritoneal, which is ambulatory at nighttime.
Yeah.
And the life expectancy without kidney function is not long. So you need to have, maybe there'll be a wearable artificial kidney. We don't know. It's been around for a little while.
Yeah, they have them, but they're just not for prime time yet.
I don't think so. So here's what it looks like. This is something that on the right you see 1,000 times a day.
Oh, yeah.
You see somebody who's sitting, who's lost their clearance, and then the thing that's sitting up there that people call the kidney, which it isn't the kidney, this thing here, wherever that thing is.
A little filter there.
That filter is supposed to be the gigantic glomerulus,
right? Where
ultrafiltrate is pushed out by generating pressures and flows, and that's supposed to be a low resistance thing, high conductance things that keeps the cells in, like the glomerulus, and the proteins in, but pushes out an ultrafiltrate that then gets removed and replaced by a dialysate, which has got good stuff in it.
Right.
But here it is. These are the pumps and tubing for countercurrent flow. There's no difference between dialysis and the countercurrent flow that happens in the loop of Henle.
Right.
The countercurrent flow of blood and dialysate, two fluids.
Except we don't alter our permeabilities at all in that thing.
No, but what we can, or that's right. Because it's too hard to do.
So we do all driving force manipulation.
Right. But the benefit is, yes, you're right about that. But the one thing we do get, now dialysis is mostly diffusive, but to the extent that you get the two fluids going the other direction and some stuff being pushed out with pressure, that's convection.
Yep.
Okay. Whereas when you did CVVHD or whatever you did this past week when you were on call,
right,
there's more of a convection going on. Hemodiafiltration is more of a convection. But the combination of diffusion and convection, dialysis is mostly diffusion, little convection. Our other replacement therapies are more convection than dialysis, than hemodialysis. So that's again flow. And again, what is the dialysis machine reading out to you? They're reading out to you the blood flow rate, the dialysate flow rate, and you want those flow rates to be high while not setting off the pressure alarms. Right? So again, it's flow that's primary, and you want to see that you get away with it by keeping low pressure. So you don't set the pressures, you set the flows.
Right. Well, you do set the pressures because it's actually the TMP, it's the transmembrane pressure that's regulated in these machines. But
well, that's because it's a machine.
Right, exactly. And that's what we can do.
And it's probably measuring voltages to do that.
Right.
So again, for the circuit, it's easier for it to deal with voltages. So the driving forces that need to be measured are going to be voltages. But that doesn't mean it's the best way.
No, that's for sure.
Yeah. Okay.
Well, we know the best way.
We know the best way.
That was your other slide.
Yeah. Well, this is it. So here's the anatomy of a kidney transplant. So there is a surgeon, I hope it's a surgeon, holding a kidney about to transplant it. You see the ureter hanging off there, and hopefully enough renal artery and vein to sew it in. And so, I know a person who's got 5 kidneys. Okay, how many? You probably know some four.
I know some 4 kidneys.
Yeah. So most of the time, people don't know this generally, but most of the time we leave the native kidneys in for 2 reasons. One, they're not easy to take out. 2, they might still have some residual. Okay, you never know.
Right.
And then we put the new kidney in the pelvic fossa, and sew it into the iliacs. Okay, and then run the ureter to the bladder. Right. So the bladder's
pretty simple 3.
Yeah. So the bladder's got
pipe hookup.
The bladder's got its 2 holes for the original ureters, and then a 3rd hole or a 4th hole or a 5th hole for the new kidneys.
Yeah.
Because again, the reason some of these people have kidneys stay in is that a transplant kidney, I think, is even harder to take out than a native kidney. So anyway, that's the kidney transplant. So again, what nature unites. So
it is pretty amazing. Go back to that slide.
This slide.
Nope.
This slide.
Yeah.
Okay, go ahead.
Because with huge machinery and filters and our best,
the best we can
technology and the best we can do, we can't do as well as this little thing
I think
in the hand.
You're right. So
it's incredible.
I think many patients have noticed.
Oh, yeah.
Why is this thing that's the size of my fist that I only need one of?
On the inside.
And they need this huge machine. Now, the comment I'll make about that is I think it's important. There have been lots of efforts to make, quote, the artificial kidney.
Right.
And so the question is, if you sit down to make an artificial kidney, should you try to make an artificial kidney that actually works like the native kidney that by necessity has had to make all these changes over thousands of years? Or do you start from a different place?
Right.
Now, personally, I would start at a different place because the problem is different. We don't need to dump everything into Bowman space. We don't need to recapitulate everything the kidney does in terms of its mechanisms of GFR.
If you can come up with a smarter way to do it.
Yeah. So I think from an engineering point of view, and I'm no expert, from an engineering point of view, if somebody said, look at
what the end product is. How do I get from A to B?
Right. Your semester project is to replace the kidney.
Right.
And you got 2 design choices to start with. Start where the kidney is, okay, and do it like the kidney did it, or come up with a new idea. I would come up with a new idea. Yeah. As much as I love the kidney.
Right. We can't replicate those processes.
Well, it's not a matter of can't. It's a matter of should. Should we? Because the kidney has done a lot of things and made a lot of choices and compromises over the millennia that were for a problem existing at the time. Mm. This is the problem existing at this time.
Right.
It would be hard for me to believe that the way the kidney does it is the way we should do it today. The kidney would even say, hey, what
you could do this better.
I think you might. I don't know. We'll have to see what happens.
Yeah, it's going to see. And Kidney X is so interesting. Do you ever check that out? So interesting.
Yeah, we'll have to see what happens. But I'm just saying, me personally, I wouldn't have tried to recapitulate the kidney. I would have said, what's the engineering problem to solve, and what's the smallest parts I can get to do it, and can I do it with? And I'll keep in mind that flow is probably important.
Yeah, that is for sure.
So anyway, the marriage, where are we today? At one end, the heart is working hard to pump a huge amount of water out of the body, for example. At the other end, the kidney tubes are working hard to defeat the heart by resorbing it all. And again, nature frequently pits 2 forces against each other. This is why we love Harry Potter.
Right.
This is what it's always said, whether it's Star Wars and the Empire versus Luke. The reason is everybody loves to see good and evil fight it out.
True.
And I'm not going to say which one's good and evil in this situation, but the kidney's good.
I got
it. And so nature does this, pits 2 forces against each other to see which one, and they fight it out to maintain the steady state. And under healthy conditions, the heart and kidney do this in a friendly way, respectful way. But our lives depend on neither one of them ever winning out completely. You can't have a heart without a kidney. You can't have a kidney without a heart.
That is for sure.
And that's for sure is right. So again, there's the circuit, and that I believe is my second to last line. Yeah. So there's the circuit again, and there is just.
Lake Champlain?
No, it's not.
No, where is that?
This is in Maine.
Oh, beautiful.
Some boats in Maine.
Nice.
So I think that so to finish up, since I know that I sent you the slides, but you didn't have time to review them, and we like to do it that way because
I think it's way better to do it that way and to just have the 2 of us.
So if you could name either a couple of concepts that you've changed your mind about a little bit, or you think a little differently about? You've known me for a long time.
Yeah.
You might have already known all this stuff because you've heard me blather on about it. But where do you think this fits into how our students should be getting taught? Is there a role there? And what does it mean for modeling and clinical practice?
I think the segment on understanding clearance is so important because we use those numbers and the heat map to describe kidney function to our patients. And I have one in every room. And when I go over it with them, I use a couple of examples. Sometimes I use the lawnmower example. I use, garbage out of the building and how much of the building did you clean? That's the clearance,
Right. That's
versus
the clearance.
excretion, which
Right.
is how much of the garbage went out.
Right.
But I think, the concept of clearance, that was an awesome review. And then the concept of flow, I think is to me moving us forward because we're behind in medicine in a lot of ways. And a lot of times we measure things that don't seem to help us or they make us work, they confuse us.
Right.
And they might even make us make mistakes about doing things.
So why do you think, given what you just said, which I agree with,
Yeah.
what do you think accounts for that I couldn't find much of this stuff to make me, I felt I must be crazy because, this doesn't get a lot of talk.
Right. No, I agree. I looked and what I found was lots of little educational stuff on clearance.
Yeah.
Basic GFR,
Yeah.
inulin, creatinine clearance.
And you'll see
when
things,
you look
and
at
you'll
it.
see people talking about the afferent and the efferents.
Yeah,
But
regulation.
In terms of the big picture of taking it down from waterfalls
Right.
and coffee makers
Right.
to
No, I think the way this was laid out was super educational.
But I just wonder. Maybe we're wrong. Maybe this isn't the best. Maybe this is. To me, I think it just breaks down the concepts. It breaks down the barriers, and facilitates my understanding of the concepts. And also the way the body works.
For people who want to understand glomerular filtration and single nephron GFR, this podcast is the best you're going to find.
Well, I hope you're right.
And I think you did a great job laying that out. And
well,
I
thanks.
learned something for sure.
And I think it sets the stage for us to talk about AKI.
Yep.
And CKD and dialysis and transplant and blood pressure.
Yep. Perfect.
So we're not done yet.
We're not done. We got much to do. We have to work on our Zoom method of getting together.
You betcha.
Yeah. Alan Segal, thanks again for coming over here and working your magic as you always do.
Lots of fun, Craig. Lots of fun. Lots of fun in physiology and flow.
You got it.